space of the health system. Now I want to discuss about the artificial intelligence, about the telemedicine, about introduction of digitalization in all the field of medical practice. I think all these challenges should be under an umbrella of and the leadership of Ministry of Health, of the National Insurance House, which have to work together to be able to put in place these changes. And our forum is maybe one of the most relaxed, I should say, and more professional and more with a vision meetings that are able to have very clear messages and this concept of Aspen to put everyone together who have interest and competence in the same time in the health sector, I think is the right answer to deal with these challenges. Thank you very much for inviting me here. You know that starting with 2017, and I want to thank you to the acting president of Aspen Institute, he mentioned this, we try to extend and to have a broader approach and to have a lot of international experts in our meetings. And I think in the last 6 or 7 years, the quality and impact of these meetings were visibly improved. Thank you very much, and I hope today will be a very fruitful meeting, and at the end we'll have some important messages to bring also to the mass media after this meeting. Thank you very much. And I want also to thank, and I'm sorry I was not able to participate last night. I want to thank also to Miss Mircea Joana, who is the founder and the engine of this important institution, which is Aspen Institute Romania. Thank you.
Thank you again, Minister Gafila, for your keynote address. Ladies and gentlemen, approximately 1 month ago, Aspen Institute Romania officially announced the launch of our Chișinău office. The coming months will continue to focus more and more on the Republic of Moldova over the broad spectrum of our activity as Aspen Institute, reaffirming our strong commitment to support Republic of Moldova in order for it to reach its European future. Therefore, now it is my pleasure to invite on stage Secretary of State Dr. Ion Prisăcaru to deliver a keynote speech on behalf of Ms. Ala Nemerenko, Minister of Health of Republic of Moldova. Welcome to the Aspen Healthcare Summit, Secretary of State.
Thank you. Good morning. Bună ziua. În primul rând, permiteți-mi să mulțumesc pentru invitația la acest eveniment și oportunitatea, de fapt, de a povesti ceea ce este în Republica Moldova și de a spune ce planuri avem și de ce este important acest eveniment și o să încerc, de fapt, să explic detaliat acest lucru. Republica Moldova a moștenit, de fapt, un sistem de sănătate sovietic cu infrastructura sa, eu știu, anumite proceduri, protocoale, care desigur că la momentul actual deja nu mai sunt actuale și necesită schimbări majore pentru a corespunde standardelor europene, standardelor actuale. Și aici, dacă ne referim la fiecare parte, domeniu din sistemul de sănătate, pot să spun că cel puțin dacă începem cu medicina primară, da, care a suferit enorme modificări în această perioadă și, de fapt, în această scurtă perioadă, noi am reușit o evoluție destul de bună a sistemului de sănătate. Avem o medicină primară care corespunde necesităților și acum nu putem spune că nu avem vreo localitate în Republica Moldova care să nu aibă un oficiu a medicului de familie, cel puțin, sau un centru de sănătate, sau un centru a medicilor de familie. Absolut fiecare cetățean este asigurat cu asistență medicală și dacă vorbim de o problemă enormă care, la sigur că nu este doar la noi în țară, este și în România și în orice țară europeană, este deficiența de resurse umane, atunci în medicina primară noi din 2200 cam de funcții de medici avem un lack, o lipsă de 172 doar de medici și consider eu că cel puțin în domeniul medicinei primare am avut o evoluție foarte bună și continuăm acest lucru cu diferite experimente la un moment dat, cu diferite pilotări, una alta, însă mergem destul înainte. Problema majoră pe care în Republica Moldova o avem acum este cu domeniul spitalicesc, care, spuneam, este construit după un model sovietic și, de fapt, vă spun așa, avem vreo 75 de spitale în Republica Moldova, iar este construit după modelul sovietic, în fiecare localitate practic trebuie să aibă un spital. Desigur că aceasta necesită costuri foarte mari și de întreținere acum, dar un alt aspect care trebuie luat în considerare este faptul că, conform Biroul Național de Statistică din Republica Moldova, în ultimii 20 de ani noi am pierdut jumătate de populație din țară, de la 4 milioane jumătate de populație în anii 90, acum suntem 2 milioane jumate și urmează acum un recensământ chiar în lunile următoare și am impresia eu că nu o să fie mai mult de 200, cred că acum. Respectiv, toate aceste aspecte au necesitat reforme substanțiale în sectorul medical și, din păcate, a fost o perioadă de stagnare ultimii ani, inclusiv pandemia ulterior, la fel a bulversat un pic acest sistem, însă avem acum adoptată o strategie națională de sănătate în anul 2023, și se numește Strategia Națională de Sănătate 2030, care de fapt presupune că până în 2030 avem de făcut foarte multe lucruri, inclusiv de reorganizarea sistemului spitalicesc și de urgență, iar aici nu sunt în detalii, desigur, dar de ce am făcut această introducere, fiindcă spuneam că o să explic de ce este foarte importantă participarea noastră la acest eveniment și de ce contăm foarte mult, de fapt, pe parteneriate externe, fiindcă Republica Moldova rămâne totuși o țară foarte mică. Necătând la toate eforturile noastre și avem succese foarte bune în domeniul sănătății, eu sunt sigur că avem ce prezenta exemple de reorganizări foarte rapide și eficiente și adaptări la situațiile curente, totuși rămânem o țară mică și chiar dacă am devenit candidat la integrare la țară, membru a Uniunii Europene și anul acesta a fost recent, acum a votat, aprobat de Parlamentul European și inițierea procesului de negociere pentru calitatea de membru, totuși este de multe ori ne întâmpinăm cu o problemă majoră și anume faptul că companiile mari, companii importante care ne-am dorit noi să fie prezente pe piața Republicii Moldova și mă refer aici inclusiv la piața farmaceutică, din cauza unui poate un număr mai mic de vânzări preconizabile, poate nu-și încearcă la noi să inițieze aceste discuții, să fie prezenți pe piața noastră și inclusiv în acest context noi am liberalizat foarte mult această piață a medicamentelor, noi am pornit un proces nou inclusiv de procurare a medicamentelor de către Compania Națională de Asigurări în Medicină, fiind un buyer, un cumpărător angros, să spunem așa, pentru a influența cât mai mult companiile străine să vină în Republica Moldova, să aibă o predictibilitate, avem un proces de negociere foarte transparent și pe această cale eu, de fapt, invit companiile rezidente în România, companiile internaționale, să atragă atenția asupra noilor modificări și legislații din Republica Moldova, atât cei ce țin de piața farmaceutică, a dispozitivelor medicale, dar și cei ce țin de digitalizarea procesului medical, implementarea activității de telemedicină în Republica Moldova. Avem acum foarte multe activități și încă o dată accentuez faptul că suntem foarte bine dispuși să avem parteneri externi în acest domeniu și în acest context mulțumesc mult Guvernul României pentru faptul că de fapt este cel mai strategic partener al nostru la momentul dat și o multitudine de proiecte sunt implementate prin intermediul Guvernului României sau chiar cu implicarea directă și inclusiv a fondurilor din partea Guvernului României. Aceasta ne ajută foarte mult să implementăm anume acele reforme și strategii care ne le dorim și le merită de fapt populația să o aibă la noi în țară. Obiectivul principal al strategiei de sănătate 2030 este să aibă fiecare cetățean să aibă un acces echitabil și la un serviciu medical calitativ. Ne-am propus acest lucru și vă promitem că o să venim de fiecare dată cu noutăți la acest aspect și o să-l ducem la final fericit, la sigur. Mulțumesc încă o dată și doresc succese evenimentului. Mersi.
Good morning, everybody. We have now a pre-recorded message from Mrs. Natasha Azopardi-Muscat, Director of the Division of Country Health Policies and System from the World Health Organization. And after this, we will start with the panel directly. Thank you.
Good morning, dear colleagues. It's my pleasure and privilege to be back here again to continue the important discussion about the importance of innovation in our healthcare systems. Innovation is at the core of all our work because it is unquestionable that health systems have to continue to shift and adapt to new reality. Some of these shifts need to be rapid. For example, as we've seen during health emergencies such as the COVID-19 pandemic. Others take time and careful planning to ensure that innovations are not disruptive and that they are implemented ethically. Over the past year, we have held a series of high-level events covering several important areas also being discussed here today, including health workforce, digital health, and hospitals, among others. And I would like to briefly touch on the main themes that emerged from these events. During our meeting on the health and care workforce in Bucharest, we talked about the importance of innovation in the way health workforce teams are organized and skills distributed to deliver quality health services. We also discussed the importance of optimizing the use of public funds to ensure effective health workforce financing and effective use of digital technologies to support our health workers. At the regional meeting on hospitals in Baku, we discussed the future role of hospitals, not as an isolated part of the healthcare system, but their role in integrating health services across the continuum of care. In September, in Porto, we hosted our second Digital Health Symposium, where the key messages were around ensuring that technologies benefit everyone equally, are safe and reliable, and calling for an ethical use of artificial intelligence, AI, in the health sector. Despite these promising messages about the future of our health systems, any changes depend first and foremost on trust. The trust of health workers, feeling that they are valued and supported. Trust among patients in the quality of care that they are receiving across the care continuum, and trust that digital innovations are there to serve all without leaving anyone behind. This is why trust will be a key theme at the heart of our Health Systems Conference in Tallinn in December, where we will gather to celebrate and commemorate 15 years since the adoption of the Tallinn Charter in 2008. This event stems from the recognition that trust and transformation of our health systems must go hand in hand. If health systems are to transform and innovate in ways that ensure trust, patients will then value the care they receive. Health workers will feel supported and appreciated, and the healthcare policies will ultimately make a difference in people's lives. Next week, Ministers of Health will gather in Astana, Kazakhstan, to discuss, among other things, the new framework for action and resolution on the health and care workforce. This will be such an important moment for the millions of health workers across Europe and Central Asia. It will serve to cement political commitment and make meaningful change. In this new framework, we put health workers at the center, calling for a rethinking of the elements needed to deliver effective and appropriate person-centered care. It is my hope that these themes will also emerge during the Aspen Summit, and I look forward to any follow-up discussions on my next visits to your beautiful country, Romania. Thank you.
Thank you, and now I invite the distinguished members of the panel shifting the paradigm towards a prevention-based system to join us here. And I'm welcoming the Presidential Advisor for Health, Mrs. Diana Paun, Mr. Mikash Micoli, Mr. Radu Gănescu, Mrs. Mirela Iordan, Mr. Cătălin Radu, and Mr. Marcelo Pascual Morales. I will be very brief in my introduction. I will take note that we have a very balanced panel with a representative from all the important areas involved in health, meaning the authorities, the scientific area, the industry, and not the last, the patient are represented in this panel, and we'll see both the Romanian perspective of the prevention activities and also what is the situation at the wider level, at the European level, and also at the international level in this area of prevention in, I would say, very timely meeting we have today, meaning in the moment we introduced, the Ministry of Health introduced the compensation for vaccination in Romania. So I will give the floor directly to Mrs. Diana Paun, the Presidential Advisor for Health. Thank you.
Thank you, Professor Vladescu. Good morning to everyone. It gives me a great pleasure and honor to be here today, and I want to thank to Aspen Institute Romania for inviting me to be panelist in this important session dedicated to shifting the paradigm towards a prevention-based system. And I want to share with you some ideas about prevention, because prevention is one of the main topic of the presidential administration in public health, and also is a topic so close to my heart. Why is this? I believe that prevention should be the main principle in public health. Therefore, investing in core capacities at the national level is fundamental. Unfortunately, for many years, this fundamental principle has been set aside as being low importance. And pandemic highlighted us the devastating consequences of this approach. As you are aware, the presidential program has made prevention and health education a top priority in public health reform, believing that only by healthy lifestyle, by promoting health education and raising awareness about prevention, we can have long-term effects on quality of life and well-being, and also for life expectancy. We are talking about the patient-centered approach, and also the challenges generated by the actual context indicate the rethink of the architecture of the whole public system in Romania to place health education on the center. And it is possible by targeting 3 levels: information, education of the whole population in medical field. Second, acquiring attitudes and skills that is favorable to health, as well as the active involvement of the people, of the population, of medical doctor as a model, but also of the patients in maintaining their own health. In practice, the success of implementation of a prevention policy depends on many factors, but the most important is the financial one. It was a discussion on my table with Ministry of Health, how important is to have a better financing of our healthcare system. So we have to rethink the payments and the reimbursement mechanism at the level of our healthcare system in order to shift the paradigm with focus on prevention component. So this was the main idea for the beginning, and I'm very happy to be here with you in this important panel. Thank you.
Thank you very much for your overview of the system. And I will, given the time restraints, I will go directly to the presentation of Mr. Mikash Mikoli. I think he will present us the importance of a good diagnosis as a part of a prevention strategy, and to see what is the gap between diagnosis and treatment. And I'm sorry for saying Mr., Mrs., I suppose. So please, I give you the floor.
Hello, everyone. My name is Mikashmi. I'm here to, I'm wearing 2 hats today. So I don't know how many of you know that the WHO actually passed a resolution on diagnostics this year. And being on this panel here today, which we are talking about prevention, and the moderator very gracefully talked about vaccines. But what I do want to talk about is diagnostics. If you're talking about what we want to prevent or what do we want to treat, unless you don't know what it is, we are running in blind. So last year, the Lancet Commission was published a report on diagnostics, and I was one of the commissioners and the co-authors on that report, and I do want to bring to light what the findings of that report were. So the context here and the background was that in 2018, the commission was put together. There were 25 commissioners from 16 different countries. From 16 countries with different specialities of radiologists, people from ministries of health, health economists coming together to ask one question: why is diagnostics important? And what is the evidence of why should I be caring about diagnostics? So this is how I try to summarize the report very quickly, which is over 55 pages. One is the part of evidence. So rather than saying, let's invest in diagnostics, let's think about prevention, what do I need to put at primary care or in hospitals? So we put together some evidence on diagnostics, which I'll talk about in a minute. And from that evidence, we came to some recommendations and key messages. The first one, and one of the speakers in the morning spoke about the continuum of care. And this is what we call the care cascade. So if a person really comes into a public facility or any hospital, it's the person. It's not a disease coming to your doors. So the person has symptoms. You really need to understand what the person has. So he or she needs to go through diagnosis, and the person needs to get treated, etc. We looked at 6 conditions of this care cascade for this commission. And when we looked at these 6 conditions of diabetes, hypertension, TB, HIV, malaria, there was one thing which was common in all 6 conditions, that the orange bar that you see here on this chart is the diagnostic step. And the biggest gap in all continuum of care was diagnostics. So we looked at the data. There were over 16 studies, and this was not just low and middle income countries. Even in high income countries, the biggest gap was diagnostics. And it was ranging from 32% to 35% to 62%. So then we wanted to see, okay, this is the biggest gap, but why is it happening? Then we looked at the other evidence putting together. We said, is the diagnostics really not available, or is it bad quality of diagnostics? What is it that we are missing here? When we looked at the evidence from just 10 countries at different tiers of healthcare, whether it was primary to hospitals at tertiary care levels, we saw that as basic as a blood glucose was not available. As basic as a hemoglobin was not available. And coming back to the topic of the discussion here, which is prevention, we do need to know what a blood glucose of a pregnant woman is. We do need to know what the hemoglobin estimates are. There are many risk factors associated there. So we really need to test for these parameters. But the availability was really suboptimal. And to talk about imaging, even imaging, for example, ultrasound or CT was not available. And to mention again, these are the tests that you really need to do for a person, either to diagnose, to screen, to triage, or whatever. But that was missing. One of the big questions that people ask, and this was a lot of people from the World Bank, EIB, and the Ministries of Health asking us, why should I invest in diagnostics and not in pharma or vaccines? So we did a cost-benefit analysis to say, every dollar that you actually invest in diagnostics, there are a lot of returns. And we did this in quantitative terms, and the graph is here. Obviously, the cost-benefit analysis will show that if it's an infectious disease, you're going to have more returns. The transmission is going to be less if you can detect it sooner. And for high-income countries as well, and I'm speaking here sitting in Romania, the returns are going to be higher than any low or middle income country because the morbidity and the mortality that you actually avert is going to be higher. So based on the evidence, we gave some key messages stating that 47% of the global population has little to no access to diagnostics. So we are running in blind, basically, trying to treat people for which we don't know what we are treating them for. Diagnostics is underfunded. It was only during the COVID pandemic that people really understood the importance of diagnostics. And just when we were doing our analysis, we came to a conclusion that only for those 6 conditions that I mentioned, if we just reduce the diagnostic gap we can actually avert 1.1 million deaths annually, which is a big number just for those 6 conditions. And then I realized this morning that we were speaking about the Minister of Health from Romania. He spoke about the national health strategy. I do request to all the prominent speakers and people present here, we do need to underline the importance of diagnostics. So we need a national health strategy, but we also need to underscore the importance of diagnostics in that health strategy. And these were some of the recommendations that we came out and published in the report as well. You need to have a diagnostic strategy. You need to have a better regulatory framework. You need to think of innovative, and my previous speaker, she spoke about reimbursements and to reduce actually out-of-pocket expenses. And this is what we are talking about in the entire diagnostic strategy or the health strategy that the country has to come up with. The international recommendation, one of which was just published, was the World Health Assembly resolution. And the last one here is on the Diagnostics Alliance, which is again a work in progress as we speak at the WHO. Just switching the gear to a little bit of positive side, all of that what we showed was evidence existing from the past so many years. But the COVID pandemic actually showed us, and this graph was something that we did at FIND, was to say that it is not that countries cannot do it. We saw that. If we really have to put our eggs in one bucket, we can. And this was the capacity in just a couple of countries that from 2021 to 2022, there was an exponential growth in how people can put their technologies together, their brains together to really amplify testing. So, and this was again a positive thing that happened for the first time ever, a resolution on diagnostics. This is just something that I wanted to put together in context of Romania. We do know that and this is a publicly available database here at IHME, looking at 2040, the disease burden looks like we are going to have to put a lot of investment in non-communicable diseases. The top 10 are actually non-communicable diseases. And that is where prevention is really important. If we can catch it faster, we'll obviously be averting death, morbidity, and mortality. Lastly, just trying to link all of that together, we need to have a national diagnostic strategy along with the health strategy, which needs to think about screening, surveillance, imaging, prevention. And we need to think about essential packages at a more decentralized testing. And integrating all of that with health information system using AI, digitalization, having connectivity tools. You can't be just getting a patient tested and not then putting them on treatment. You need to have a continuum there as well. And yeah, lastly, I would just like to thank you all for your attention and happy to have any questions. Thank you.
Thank you very much for your presentation. It somehow complemented the previous one of the presidential advisor. She talks about both education and financing. You touch both of them and show the importance of both of them in early diagnosis. It will be interesting to see if in Romania we can follow up doing some studies on this diagnosis situation. Probably in some areas there is a huge underdiagnosis, especially in some forms of diseases in which the diagnosis is important to be done in early stages. Having those two views from the authorities and from the scientific world, I will give now the floor to see the view from the patient perspective.
Thank you. First of all, thank you for inviting me here and to be part of this panel. I'm honored. Yeah, we can discuss about diagnostic, and it is what we discussed the last year about access to screening, access to prevention, vaccination. But let me start a little bit with something else. I think prevention, when we discuss about prevention, we start from early age. And we start from our education and from our children about how we maintain our diet, what we eat, what we exercise, and things that we learn home or in school. And I must say that I'm very sad that what's happened now in reality. I'm looking at my son colleagues from the school. Half of the class don't do exercise. Many of them, the parents go to school, or some of them even ask me if I know a doctor to provide them exemption from sports. I ask them why. I don't know why to do sport. It's not important sport. I was raised by my parents. When I was in school, I have my sandwich from home and an apple or orange or fruit every day. Now the parents give to their children money to buy Energizer drinks, to buy candy, and things they eat every day. And we, in my opinion, and I'm not a specialist, for sure, this kind of education will have effects in the future, effects in the population when they will grow up and be adults. And I don't know if we can do something to change that or not, but I think this is the first problem. And we see it every day, but probably we don't have knowledge of the effect. And I'm stopped. This was just an introduction, if I might say. After these slides, and I must say that I saw a big difference, and maybe I don't realize in reality what the big difference it is between diagnostic and treatment. We know that it is delays, but maybe we can improve it, and maybe we can do something step by step. And first of all, I think it's to have prevention programs. And this year, I think, is the first year when our national health insurers put in their service compensated prevention for the GPs. And this is a first step, and I think it's a big step. What is next step is that GPs do indeed prevention in the population. Because if I have a disease since I was born, and I go to my GPs, I don't know how many years, never he recommended me to do, I don't know, screening, or to do some investigation for possible problems that I don't have. And being a patient, for sure, if I look into, well, I will find something like a complication. But I think it's a lack of communication between patient or between citizen and their GP. The citizens are used to go to the GPs, you know, I need a paper, I don't know, I need a recipe, or I need something from my son in school, that's it. No other dialogue, no other communication, no other discussion about what we can do in the GP office. It's something that we miss in our way to discuss with our doctors. The second part is the idea, not the idea, the tradition. I do not go to the doctor because I'm healthy, I don't have nothing. We don't have this education of going to the doctor when you're healthy, not when you're sick. And I think this is past in the years before, when we avoid to go to the doctors, and when we say, and I even now in these days, some of the patients say, you know, if I'm going to the doctor, for sure they will find me something, and I don't want to go to the hospital. I hate hospitals, and many people think that hospitals are something bad. I don't know, because probably we see a lot of things. Maybe it's not a promotion of the good things that happen in our hospital, of innovation that have now in Romania an accessibility for a lot of patients, but indeed, like other zone, it's also good things and bad things. So we need to bring population, besides education and awareness, we need to bring population much closer to the doctors. And we need to change the shift of the paradigm that we need to go to the doctors when we are sick. No, we need to go to doctors when we are healthy, because you can prevent to be sick. The accessibility now, we even discussed before that now we have even access to vaccine by compensation. It's a big step before. We discussed many years. We started to have these kind of little steps, but the population need to know. And I had an event about vaccination a couple of weeks ago, and someone after the event came to me and asked me, indeed, I can go to the drugstore and take my vaccine? I said, yes, you can do it. Wow, I didn't know that. And we discussed in Bucharest, but if we go 20 miles, 30 miles from Bucharest, it's another world. And I think it's important for us, everyone that we are here and everyone that we discuss about prevention, to put our, let's say, capabilities to spread the awareness, to spread the information, and to make educational programs for the population in order to understand how important is prevention for their health. We know as a authority, doctors or patients, how important is the health for you, but I think we need to spread the level of the information even in population much more. And we can do that if we can offer programs like the programs that I said before, and just tell them, you just go to the doctors and that's it. No need to have, I don't know, anything else to pay or to buy or to do or something else. You need just to go to the doctors, have a discussion, and probably you can avoid a lot of things. And we had a screening program in cancer, colorectal cancer, here in Bucharest, and we find patients with cancer in early stages that are now healthy and treated, and they came to me and say, probably in 2 months or 3 months will be dead if this screening program didn't have access to him. And he realized, I didn't have any symptoms, I didn't have any pain, I just took the test because my wife said, took the test, free, and I was cured by a disease that possibly in the future, the next couple of months, would take my life. And now they realize this kind of citizen that had been so close to a disease, they realize how important it is to do prevention. I think this kind of example, we should put it in our society to show and to explain what is prevention. I will stop here because I think I talked too much, but thank you for having me this opportunity to say.
Thank you very much. You touch some issues which are, I would say, both of interest today, but they are taken into discussion over and over in the last decades, I would say. For instance, you mentioned that you didn't have any type of prevention advices from your family doctor, and this is a topic to probably to be discussed both with the representative of the family doctors, if there are any of them here, but also with the health insurance house representative to see if they have any type of incentive to shift the focus of the family doctors towards prevention, because as it's always emphasized, the best way to do prevention is at the primary healthcare level. And also you mentioned something which also it's ongoing in the Romanian society, the huge divide between rural and urban areas. What is prevention sometimes which is developed at the urban area, it's totally missing in half of Romania which lives in rural area. So with these notes, I will give now the floor to, we shift towards the industry, and I will give the floor to the country manager of Pfizer Romania, Mirela Iordan.
Hello, good morning, and thank you so much for hosting this important event. I think it's a long history since it was founded also in Romania, and I was part of this history, and I see the progress. It's the progress towards digitalization in healthcare. It's a progress also in the innovation, how we advance innovation in Romania, and even sometimes we have ups and downs as a society, economy, and we need to face all the situation as we had recently in Romania, the public financial deficit. So we need to be stronger together, first of all. And when we speak about together and collaboration, we speak about public and private, we speak about authorities, medical community, we speak about academia, and there are things that are happening when you collaborate. From the perspective of Pfizer, as a US-based company and present in Romania also, we celebrate this year 30 years, and I am part of this history with 23 years. I will say that Romania has a strong reputation also in among Central European countries, and together with Poland, also we have in the cluster Greece, Malta and Cyprus. Romania is one of the big three countries. So the investments that are coming here to support innovative medicine, to support promotion of education, to support access is a top priority for Pfizer in Central and Eastern Europe. Coming to the future, because we speak about what next. So I think that the pandemic crisis all over the world give us lots of lessons and accelerate many areas, especially in the digital technologies. Of course, the new technologies means new medicine, new vaccines, because the technology is at the speed that sometimes the humanity is difficult to understand, and we face it. That's why the trust is everything, and the trust is coming with hard data, scientific education, not uncontrolled rumors. Because unfortunately, all over the world, it's not only Romania, social media is the channel for information at hand for everyone, from teenagers, from senior people, from adults, at any ages. So both when we speak about new technologies in life science, or if you speak about new technologies that penetrate the healthcare systems, the ethics, the science, the data should be really careful, regulated, and of course, validated by authorities. And we have also big progress with the National Drug Agency, which is our regulator for the medicines and vaccines, because there are important steps in approving disease awareness campaigns that are in partners. We have partnership collaboration with medical societies to really spread the signals, the symptoms, and how to prevent certain disease that, of course, lead to long disabilities, sometimes with not only the hospitality rate is increasing, but also the death, the mortality is increasing. So Romania, we know very well, we don't have a good position in preventable disease. So that's why prevention is a key. It's not limited to vaccination, but immunization, it's still from the early stages, from the first months of the newborns until the people 65 plus that need to be protected. So when it is a vaccine, when it is a protection that has an immediate effect, I think that time is life. We should not have any doubt when some alternatives are validated globally and also regulated by National Drug Agency, by European Medicine Agency, or by FDA. Coming to technology, because it's also important, we speak about registries, from patient registries, disease registries for many, many years. I think that also medical societies are coming to an alignment that it's an important, very important need to use the data that we have in terms of efficacy, in terms of life expectancy, especially in the treatment where, like cancer treatment, where now we look for years of surviving and not months. And for Pfizer, of course, cancer, it will be at the core of the strategy in the next years by 2023. We also develop new vaccines. Now the future will be, of course, to combine certain type of preventable disease in order to have one administration instead of multiple administrations. So there are big progresses. Coming to other technologies, because we know that in Europe there are 24 new gene therapies or new technologies that are approved. And of course, it will come also in Romania. We discussed in the morning about these digital technologies that need a different legislation, a different framework in order to be able to give access for Romanian patients. And sometimes when it's a case that we know very well that we have a treatment in Romania, when it's a case of a lymphoma or a disease that really needs a life-saving cure, you act immediately, and you should have that framework in order to be able to get access for your son, for your father, or for anyone that is in need. But of course, financing, it will be at the core. And giving these figures, we know that during pandemic, maybe you allocate more funds to the healthcare, but now we come back to the bottom line. So we are far from the European average, which is 8.1. So we still fight for some supplementary budgets at the level of National Insurance House. We hope to collect more money also from the insurers, insured people, because it's in the benefit of any citizen. So there are important things that we look positive and optimistic to the future. But this is coming only with collaboration and also encouraging science, and we speak here about the life science, to have a word, to have a place, controllable place, not in the virtual world that sometimes lead to incorrect education or misinterpretation, and this is the most dangerous. Thank you.
Thank you. You touch and open a lot of areas of discussion for the Q&A session, from funding the system towards the digital tools, artificial intelligence, vaccination, education, awareness. So you are involved in a lot of areas. I particularly like your, let's say, introductory comment saying that Romania is in the big three countries. I think it's the first time I heard that Romania is in big three anything. I suppose it's a positive big three, so maybe we can also discuss in the Q&A session what does it mean for the Romanian health system to being in big three. Thank you, and I will give the floor now to the General Manager of Bristol Myers Squibb Romania, Cătălin Radu.
Good morning. Thank you very much. Thank you for having this honor to stand here, to speak here. I will start in English, I will switch to Romanian, and I guess you will realize why. It's very simple. There are certain things from a wording construction that can't be translated exactly. So without putting too much burden on our colleagues that are translating, I will also try to explain. I have a dream. How many of you know this sentence, where it's coming from? So please don't be shy, just raise your hand a bit. I think everybody knows. But how many of you do know that this sentence came up like last minute in something which is probably the most memorable speech that we all know? It came up because next to Martin Luther King, Mahalia Jackson said, "Tell them about your dream." His speech was worked for a long time with advisors, etc. But "I have a dream" was like last minute inspiration. Și eu am un vis, dar nu e de inspirație de ultim moment. Îl am așa, de acolo, spre un an. Și mă gândeam că 2024 e un an greu. Avem alegeri, fai de mine, câte nu mai știm să numărăm. Dar visul ăsta al meu, și Mirela a spus o cifră pe care domnul profesor Vlădescu a sesizat-o și a zis că i-a luat parte din Q&A vis-a-vis de finanțare. Visul ăsta al meu este pentru o Românie nouă. De fapt, mai corect, o Românie de nouă. Și când am împărtășit cu altcineva ideea, zice, cum adică de 9? De 10? Zic nu, de 9. Că pe acolo, pe undeva, este finanțarea, investiția medie în sănătate în Europa. Eu aș fi foarte fericit cu România aia de 9, nu cu România de 10. Dar aș fi la fel de fericit sau chiar mai fericit dacă România aia de 9 o să fie undeva în 3 ani. Plecăm de pe undeva de la 6. Avem ambiția să-i prindem pe alții din urmă. Nu avem cum să-i prindem din urmă decât dacă alergăm mai repede. Dacă creșterea investițiilor este mai mare, pentru că nici ceilalți nu stau pe loc. Cu investițiile în sănătate. Și am spus cuvântul investiții și o să-l repet. De ce? Inovația este un mindset. La fel de mindset este și prevenția despre care discutăm în acest panel și care este un obiectiv central pentru eveniment. Dar la fel de importantă este schimbarea acestui mindset de la a spune, domne, cheltuim în sănătate, către investim în sănătate. De ce este important să nu uităm că investim în sănătate? Pentru că dacă am reduce cu 10%, nu mai mult, 10% timpii neproductivi din concedii medicale sau dizabilități, România ar câștiga aproape 3 miliarde la produsul intern brut, de euro, nu de lei. Mai precis, vreo 2,8 miliarde. Sunt date dintr-un studiu care este la dispoziția asociației noastre profesionale ARPIM. Am adus asta în discuție și s-a spus, nu e momentul potrivit. Și am să mă duc înapoi la Martin Luther King, la mai precis un text pe care am avut privilegiul să-l ascult și să-l disec împreună cu colegii mei la un minunat seminar Aspen și de-aia mi-am căutat insigna aseară, am găsit-o de-abia azi dimineață, dar intrasem în trepidație, am zis că eu fur cuiva. La scrisoarea lui din închisoarea Birmingham spunea, zice, mi-am dat seama că cea mai mare problemă a negrului asuprit rasial nu este ăla albu agresiv din Ku Klux Klan care vine și îți dă în cap, ci este tăcerea și inacțiunea albului mediu, care se gândește că nu-i momentul potrivit să intervină. Ei, ca să facem prevenție, ca să facem un lucru bun, ca să investim în sănătate și să reformăm, întotdeauna este momentul potrivit. Întotdeauna este momentul potrivit să schimbăm această mentalitate, să ne mutăm de la aoleu cât cheltuim și n-avem bani și n-avem acum, către hai să o facem acum, mai devreme, mai repede. De ce? Pentru că prevenția trebuie făcută în mulți ani. Caracterul unui copil, zicem noi, că se formează în aia 7 ani de acasă. Ei, în strategia națională de sănătate pe care a menționat-o domnul ministru și mă bucur că va fi aprobată, spune și ceva vis-a-vis de educația sanitară, medicală în școli. Cu un obiectiv foarte precis, în atâția ani să ajungem la undeva la 85%. Ca să ajungem acolo, vă spun eu matematic și sunt inginer și nu mă păcălesc de multe ori, trebuie să începem acum. Că altfel nu reușim în atâția ani să acoperim atâția elevi și teenageri. Nu reușim, n-avem cum. Deci trebuie să începem acum și e momentul potrivit. Citeam cumva șocat date de la Casa Națională, apropo de cei 10%. În primele 3 luni ale acestui an au primit peste 1,8 milioane de cereri de concediu medical. Implica decontarea a circa 8 milioane și ceva de zile de concediu medical. Și pentru cei care nu știu, Casa Națională începe să deconteze de-abia din a 6-a zi, pentru că primele 5 zile sunt plătite de angajator. Făcând foarte simplu o socoteală, știți cât ieșea pe un trimestru? 17.500.000 de zile nelucrate. Dacă România continuă în ritmul ăsta, într-un an de zile avem echivalentul a aproape 320.000 de oameni care n-au muncit o zi într-un an. Din mai puțin de 6 milioane de oameni care muncesc în țara asta. Deci cam așa arată poza. De aia, prevenția este cel mai bun lucru în care putem investi. Am să îndrăznesc să reformulez puțin ceea ce a spus doamna consilier prezidențial Păun. Nu cred că este cazul să schimbăm de la tratamente către prevenție, că noi nu băgăm nimic suficient nici în tratamente. Dar, într-adevăr, investind la niște sume corecte, o mare parte din banii ăștia trebuie să se ducă într-adevăr spre prevenție, pentru că nu prea se duc deloc. Nu înseamnă că avem un exces de fonduri pentru tratament. Nu vom putea evita tratamentele medicale, spitalizarea, dar putem într-adevăr lucra foarte intens pe zona de prevenție. Și putem într-adevăr treptat reduce necesarul, poate, pentru tratamente, necesarul de spitalizare. Visul ăsta al meu mai are ceva. Cumva, o țară sănătoasă este și o țară educată. Luate invers, americanii spun, și am aici surse, dar n-am să încep cu toate detaliile, spun așa, că health literacy în persoanele care au cel puțin college degree este de peste 70%. Asta înseamnă că un om care aude o informație medicală știe cam ce să facă cu ea și să ia decizia corectă. Doar 33% din cei cu below college degree au health literacy, proper health literacy. Deci dacă România va fi sănătoasă și va ajunge ca speranța de viață medie să fie cu vreo 6 ani mai mare decât e acum, că pe acolo e media europeană, sau cu vreo 4,5 ani mai multă viață sănătoasă, ar implica cumva că suntem și o țară mai educată. Sună cumva de andoaselea, dar ele se leagă foarte, foarte tare. Foarte, foarte tare. Există un indice global al competitivității, care leagă foarte corect educația, sănătatea unei nații de competitivitate. Eu cred că putem să facem asta. România a crescut extraordinar. Dar sănătatea și educația sunt două domenii strategice pe care eu personal încă nu le-am văzut ca fiind abordate ca domenii strategice. Domeniile strategice au nevoie de viziune, au nevoie de extraordinar de multă voință politică și consecvență în a aplica acele măsuri care să facă România și să țină România ca o țară prosperă. Și cred că nu e unul în sala asta care să spună, eu vreau altceva. Așa că haideți să votăm și să cerem din toate puterile platforme și programe politice pentru România aia de nouă. Ajutați-mă în visul ăsta al meu și hai să facem România aia de nouă, în sănătate, în rest să fim de 10. Vă mulțumesc tare mult!
We also thank you. It was interesting, but you started the overview of the dream in English, but the details were in Romania. So, you know, The difference between
Being a German native speaker, I still speak in my sleep in German. So, but that was probably too confusing for most.
So you have a sleeping problem anyway.
I have many sleeping problems.
Okay, okay. You know, in management, you talk about vision and dreams. You know the difference between vision and hallucination? No. In hallucination, you have more details. So, but apart from this, you touch a lot of, I would say, fundamental issues when you talk about prevention, and that prevention is not only, and I would say not mainly, a health issue, a healthcare issue, because if we'll have anything, even the 9% you mentioned for healthcare, still the outcomes in terms of health indicators in Romania won't be as good as we expect, given the money spent on health, because more important than the healthcare system, it's a lot of, you know, huge documents saying this, including from the WHO. Healthcare system touches about 10-15% of the health as a whole. The rest is done by things like GDP per capita, how wealthy is a country, access to sanitation. Still, Romania has 30% of its population without running water. It's difficult to, you know, to tackle this with MRI. If you don't have running water, you can invest in MRI, but you won't change the health indicators. Alimentation, education, nutrition, all of this. And it's important that coming from a pharma representative, you have this in mind, that maybe also put your inputs also in this area to help people, to help young children to go to school, invest in nutrition programs, and not only you know, medical part, clinical trials and so on, but probably in the Q&A session we'll also discuss about how underfunded is the Romanian health system, given that before having the health insurance system, the total budget of Romania was $800 million US. Today it's 14 billions US. But people are complaining today more than they were complaining 25 years ago when this system. So it's an important topic, and also somehow some topic to debate, the medical leave. You mentioned millions of days of sick leave. This could be explained only in two modes. Either the Romanian population is very sick, so for this they are taking the sick leave, and I would say we have data to sustain this situation, and or there are problems with the registration of this and the monitoring of this situation. And again, probably the health insurance will give us, if there is somebody from there, can give us a clue on the situation. And now I will end the intervention of the member of the panel with the General Manager of Merck Chardom in Romania, Marcelo Pascual Morales. Please.
Thank you. Thank you very much for having me, and good morning to everyone. Thank you, Aspen, for convening this forum. I think that is really important to come together and discuss about solutions for patients. And I would like to use my first few words for all the public servants in healthcare that are in this room and not in this room also, to acknowledge their difficult mission, to put in place the best strategies for healthcare for patients, and at the same time balance, all the budget constraints, right, that all my colleagues allude to. And just to also reassure our commitment to also try to find solutions together to ensure access and the best care for patients even in these challenging times. I think I met many of you yesterday in the sessions that was organized also by Aspen, and I was pretty inspired by the intervention of Mr. Joan around the future, and also something that he mentioned that resonates to me around this square on private and public partnership, and how together we can make bigger steps and accelerate changes that are needed to advance the healthcare. And I think if you think about prevention, this is essential, because it's not just us who are in this room from different sectors in healthcare, it's the community who is going to also play a key role to really advance on this journey in prevention. I want to talk within prevention specifically about the only cancer that can be prevented by vaccination, the cancer caused by HPV. This cancer costs 5 lives every day in Romania. 5 women die every day here. And we have the highest incidence of mortality of this cancer, in particular, cervical cancer, across Europe. And it's a cancer that is preventable by a vaccine, the only one. The good news about this situation is in the last 3 years, more than 100,000 girls has been protected against this cancer. And in December, a big milestone is going to happen, which is going to position Romania at the top level of Europe. You talked before around top 3. Here I can tell you we will be in this top 3 as well. The program that is going to be in place in Romania to protect against cancer, cervical cancer through HPV vaccination is going to be top in Europe. It's going to cover girls from 11 to 45, and it's going to cover also boys from 11 to 18. So this is one of the best programs that we have in Europe. And then the question is how you combine one of the best programs in Europe in terms of coverage with the strategies to prepare not just the population but also the system. To ensure like next year, when we will be here together, we are going to discuss that not 5 women die, but half or none. And how we can be aspirational on that and bold, right? So I think the strategies are going to be key, and the ministry mentioned in his opening around the approval, which I think there is a great news for all of us in this room and for our families and for the country itself. I want to mention 3 things that are going to be really important to be successful on the implementation of these strategies, and again, protect more women against a cancer that is preventable through vaccines. The first one is education. Ms. Pong talked about that, and I think that is key. And if you think about education, I mean, you want to cover people from 11 to 45. So probably the type of education that we need to run is going to be different across different people. And we will need to start to think about how to use social media. Not just us, but the public sector, the private, and how we can also partner with the new stakeholders, like influencers, which can help to convey those messages. That's one. And then the second one is the school. I think that if you look at other countries, one of the biggest changes in mortality has been by education done in schools. And UK is a great example. You have also other countries like Norway or Hungary who not just educate but vaccinate in the schools, right? So we can go a step-wise approach on this, so we can take bigger steps, be bold, and then see, those practices that has worked in other countries to help us to advance. So the education is one. The second one that I want to mention is pathways, and how we can make really easy for anyone that wants to be vaccinated to get access to these vaccines and protect against cancer. Also, my colleagues allude here to the COVID timelines or the COVID times. I think one of the biggest learnings is when there is crisis, how we accelerate things, and also how we bring different pathways to get vaccination, right? I got vaccinated against COVID in a mall, not in Romania because I wasn't here, but in Slovakia. So how we can ensure that anyone who wants to get vaccinated can do it not at the GP office, which is what is happening today. With all of the capacity issues that we are seeing, how we can accelerate opening other channels in pharmacies, as we are seeing in other countries, in France, also in UK, in the Nordics, where this way is really convenient and is accelerating protection, and not just pharmacies, but again, many other channels. And you don't need to go to Sweden, Nordics, or all of these countries. Countries like Slovakia educate and vaccinate, do mass vaccinations program once every month run by the city hall. So, we don't need to go, there are neighbor countries where we can take examples that can really help us to advance. And then the third one that I want to mention is about data, and also that was put on the table from some of my colleagues, and at the beginning by the minister, right, the digitalization of the system. You may not be familiar, but there is a system called RENF, which is owned by the ministry, which is a best in class as well. It's one of the best systems to track, and it has plenty of data. And it's more, the ability to utilize this data. There are companies who can take that data and in 2-3 weeks provide dashboard which allow at the national level, but also at the GP level, understand how you are doing on your BCR target and then what interventions you need to do to improve. So I think what is going to be really important to advance is, of course, the funding, we talk about that, but also those strategies and how we can be bold, how we can maybe take bigger steps. We have examples. We have a situation of mortality which is at the top of Europe, but at the same time, you have a best-in-class program. Not many countries have this coverage of program to protect against HPV and to protect women's, for cancer. So how we can be really bold, aspirational, and put all of these strategies in place fast, right? Because the situation requires that. We as a company in MSD are working with governments across the world on those type of strategies. And we have the expertise, know-how, and investment to drive those strategies, and not just us, because I don't think that one stakeholder can bring a solution. It's going to be multiple stakeholders together, multiple industries. And I'm pretty confident that we have all the ingredients here in Romania to make that happen. And when we will come together next year in another Aspen Health Forum, we'll be talking about how bold we are. And rather than vaccinate 100,000 girls in 3 years, we have vaccinated 200,000 girls, women, and boys in just 1 year. So I think this element of being aspirational and bold is critical, and how we can come together, public, private sector, the community, to make that happen is the other key element. So thank you very much.
Thank you. The last panelist mentioned also something which was mentioned from the beginning. No matter who was the representative of, public authorities, patients, representative of the academy, and so on, the role of the education. And with this, I think we have still 5 to 10 minutes for Q&A. I will not make any more comments, to give you the possibility to ask and to receive answers directly from the panelists. So please, whoever wants.
Thank you. It's very interesting. Just one point, and I don't know who wants to answer that, but whatever we say, we end up in a situation where expectations and therapeutic options and diagnostic options are wider, resources are limited. What do you do in this kind of situation? Usually we set a set of criteria to prioritize, and on a criteria-based system, you make hard choices. Now, prevention, absolutely, that's by far the most cost-effective way to avoid treatment, as a matter of fact. But personally, I welcome the need of a national diagnostic strategy. But again, it would be very, very wide, and some of the diseases to diagnose are pretty easy and cost-effective to diagnose. Some others are far more complicated. So that's where you have to take the hard choices. I wonder whether we should not create a set of criteria to make those hard choices. I'll give you 2 examples. One, we have a national cancer plan. Why don't we take that segment and we go straight to the bottom of the best diagnostic systems, including not only the currently available genetic tests, but also genomic tests, which are predictive, and therefore they are very cost effective over a longer period of time rather than on the yearly budget. The same applies to prevention of cervical cancers and probably a few other diseases. Another example, the link between psychiatric diseases and COVID-induced lockdown is now medically proven. It's not only that you've been locked 2 years and you hate your mother-in-law and therefore you went mad. There are now medical reasons that have been detected. But doctors, GPs, needs to be motivated and rewarded to diagnose psychiatric diseases. And they are not. Now, I don't go into the details. We know this, we know the formularies, we know these things. That's another possibility to get a set of criteria to take hard choices, because we won't be able to do all that picture that you showed. So I wonder whether Aspen, AmCham, other groups which have a systemic approach to a healthcare system should probably work to propose a set of criteria to take hard choices, because we won't be able, let's face it, to deal with all the panel, of the diseases and diagnostic and treatment options that you showed us. Thank you.
Can I take that up first? Thank you. Actually, thanks for asking that question. I can go on and on about this topic, but something that I didn't mention, but you very well alluded to that, is there is something called as the National Diagnostic Strategy, but then we need to have criteria for prioritization, exactly. And there are criteria which, again, will be tailored to every country, because if I were to say, for example, for Romania, there are a lot of non-communicable diseases. We need to start setting up those priorities, and those priorities, so the Lancet Commission with FIND, where I work now, have been working with the WHO and the Ministries of Health to tailor that criteria. Because if we say that one size fits all is going to work for all countries, it's not even going to happen in Europe, so forget about globally. So what we did come up with is a set of criteria, starting with your disease burden, starting with what you can do, starting with the infrastructure, and then putting all, and the medicine, what you can do at what level. So you have a diagnostic strategy, you have a medicine in EML that exists in every country for the last 40 years. Can we triangulate all of those evidence together to make a criteria? So I definitely agree with the point that you made. We need to prioritize, even if it's as basic as cervical cancer approaches or having ANC mechanisms. If a pregnant woman walks in, I need to have all of these tests to prevent congenital birth defects, to prevent preeclampsia or something like that. So I think there are a couple of priorities, and very happy to sit and talk through them, some of them in the Romanian context, but it will be a tailored approach for every country, for every continent. And I agree with that. To make it more impactful and cost effective, it has to be tailored and prioritized.
Can I just add to that really short on this? I think also we need to look the healthcare as a whole, not just focusing maybe on one silo of medicines. I think there is a lot of room for improvement. And we talk here about new technologies, digitalization, artificial intelligence. I think many of those interventions will bring efficiencies in the system. You can look that of how much you can reduce from one part to increase another part where there may be needs, right? So I think that holistic view will help on this case.
Yeah. One final point which I missed. The other key element to this is multi-annual budgeting. I'm sorry, we are broken records all of here. But if we introduce a multi-annual budgeting for healthcare, then you can reap the benefits of that cost effectiveness over a longer period of time. I'm sorry.
I would like...
I also have a short comment.
Please. Just to mention in the context of any public or private institution, the cost, how we control the cost is a key. And we have two types of strategy. One strategy is to cut certain costs, maybe those costs that are not really necessary, and also to look at the costs that could be avoidable. So which cost, or if in any medical stages, could be eliminated and maybe replaced by something that is cheaper. And of course, if we look to imagistics, like CT, Maybe it's necessary to do all the time this investigation. So we should look with the specialist, and I'm really positive. Immediately I will pass to Mrs. Loreta Păun, because it's really important, this law 152 per 2022, which is now starting with end of August, is the way we organize and finance the prevention and also how we can educate. So there are two components. And I think that there are 180 days for this legislation through our collaboration to really make this criteria of prioritization, what should be, which diseases has the most burden on our system. Because, for example, in cancer, we know that in Romania, the leading cause is lung cancer, and it's very costly. Why not to prevent lung cancer? Why not to prevent breast cancer? Instead to have metastatic breast cancer or advanced metastatic breast cancer. There are simple things that together we can do, and we say 5 priorities for 2024 or 2024 by 2030.
I have a short comment. Mr. Muznec, we have a national strategy in the field of health, at least in the field of cancer, because as you all know, President Iohannis and presidential administration have been deeply involved in prioritizing the fight against cancer. And due to dedicated efforts of a group of persons from the Parliament of Romania, Ministry of Health, National Insurance House, and civil society, I'm talking about professionals, I'm talking about patient association and private sector, Romania has now comprehensive legislation frameworks in this field. And this is a model of prioritizing first the most important pathology. And as a comment, I want to tell you that I had the opportunity to visit last month Japan and South Korea. I visited the National Center of Cancer from Seoul and also from Tokyo. And we have definitely much to learn from these societies. But this visit highlighted the fact that also the most developed societies has the same problems, and the burden of cancer is very important. Maybe the differences lie in the state responsibility in early diagnosis and assure the coverage with health services for all population. And this is important now, not only for the point of view of quality of life, but also from the point of view of reintegration in the society and coming back to work. That's about competitivity, productivity and competitivity, like my colleague Cătălin Radu said. So we need to have a healthy population, and we have legislation focused on cancer, but we have to implement it, of course. Thank you.
If there are no other questions, I'm also glad to announce you that we are in time, so the next panel could come without delay. Thank you very much, first of all, to the panelists and for the members.
Good morning. I have the hard mission to inform you there is no break between the two panels. Da, cred că vă chem eu, nu? Da. În panel?
Should we sit right away?
invit eu ca să mai tragi de timp, știi? Good morning once again, ladies and gentlemen. I apologize for interrupting this spontaneous break, but we will proceed with the second panel. And I would like to welcome everyone to this insightful panel on predictability and resilience. My name is Teodor Blidaru, and I have the honor to moderate this panel. And I would like, first and foremost, to invite the speakers of these panels. Mr. Răzvan Prisada, the President of the National Agency for Medicines and Medical Devices, Mr. Iulian Trandafir, CEO of the Alliance Healthcare Romania, Mr. Frank Lofer, General Manager of Roche Romania and also President of the Local American Working Group Association, and Mr. Radu Rășinar, Country President AstraZeneca and also Vice President of Local American Working Group. As we have our speakers, and as we are only 4 speakers, I would suggest to maintain a longer maybe Q&A session with the audience. The topic is very challenging, of predictability and resilience. In today's ever-evolving healthcare landscape, the ability to predict the healthcare needs and ensure the resilience in the healthcare systems are very important. We all agree with that. The theme of this year's Aspen Healthcare Summit focuses on prevention and innovation. And to paraphrase one of our speakers from another event yesterday, innovation doesn't come only through technology, but also through innovative policies. So I think we will discuss a lot about innovative policies in this panel. Aiming to talk about innovative directions in policy, which contribute to the overall predictability and resilience of the systems, we have gathered a panel of experts to delve in this critical topic, discussing financing, access to innovative medicines, and ways to fortify our healthcare system. Without further ado, I would like to introduce our first speaker of today, Mr. Răzvan Prisada, the President of the National Agency for Medicines and Medical Devices. You are at the forefront of regulating and ensuring the safety of medical products in our country. Please, if you could share with us your point of view in how the national agency is contributing to predictability in the healthcare system and ensuring the availability of medicines in the system. Also, what are the key challenges and strategies you foresee in the future years as the president of the agency? And also, please allow me to put another topic in the discussion. I know you also are involved in the ecosystem, and you did innovative policies in the ecosystem of clinical trials. We would also like to hear a few directions from you on that in the future. Thank you. Răzvan, you have the floor.
Thank you, Teo. Good morning, everyone. It's a great honor for me. It's for the first time that I am able to be in front of you as a speaker in Aspen Healthcare. Hopefully, I was thinking in this morning, hopefully it won't be the last. Because we are discussing about predictability, I will take the liberty of not answering directly to your point. When discussing about predictability and resilience of the health system and systems in general, we are generally referring to financing, legislation, I don't know, managing, but we don't think also at another very important aspect, continuity in management. I was just this morning driving towards my office. I was just thinking, what does predictability mean for the Agency of Medicines Romania? And how could we discuss about predictability when looking back, I don't know, in the past 7 years? The average survival rate in office of the presidents of the agency is around 6 to 7 months. Believe me, from my own experience, that in 6 to 7 months, you're not able to recognize your own people. You can't think of long-term policies or predictability of the system. So that's why I said, having in mind that I'm in office since 1st of March 2022, this might be a sign that we could see also next year at Aspen Healthcare. Until then, we have so many things to do if we really intend to build something that is resilient, meaning something that will work out without needing a name. So we need to build things that work by themselves, that do not depend on the name of the president, on the name of the minister, or whatever. And this is something new for Romania. And because Theo, in a way, stole my idea, I usually say that innovation is not only about medicines. Innovation, I tend to, I try not to use very much the word innovation, just in order not to be seen as taking part of the industry. But innovation is not about medicines only. And we've done things in legislative field, innovation, meaning I learned something in my previous life, let's say that you can't do new things, real changes, relying on the same old people. When I say old, I don't mean their age. You can't do changes in the system relying on people that are already inside the system, that were taken over by the system. And this is my biggest problem at this moment, finding new people smart enough for being able to understand all the things and crazy enough to come to the agency beside me. If we manage to do that, we will succeed. So what we have done in this 1 year and a half, I looked out in my first month there. I said, okay, what does really mean access to medicines for the patient? Access to medicines starts before authorizing the medicine. Real access to medicine starts with the clinical trials, because as everybody knows, some of the diseases and most of the diseases that we address now, oncology is just one example, does not offer enough time for the patients to wait for the bureaucracy to do its job. They don't have enough time to wait for us to do the authorization, the assessment, the reimbursement, the protocols, whatever. Maybe not 900 days, as you say, but anyway, long enough. So, real access begins with the opportunity and the possibility of enrolling in a clinical trial that is addressed to that disease. And unfortunately, Romanian patients were not able for a much too longer period, more than 10 years, to really have access to all the trials that were accessible for patients from other countries. That's all we are asking in the end. So we started by unblocking the system about clinical trials. Of course, the next step will be HTA. It's logical to think like this. We can't address them all. The next step already began. So after that, we will take care about authorizations and whatever that will come after. For that, we need time. So in 1 year and a half, we did, I think, a good job in unblocking our part in this problem about clinical trials. Okay, we did some innovative legislative measures, let's say that. So we were able to double our rate in only 6 months. We had periods looking back, we had periods in which the agency approved something like, I don't know, an average rate of 2 trials per week. And in January 2023, we had an average of 2.4 authorizations per day. This was a great effort, of course, but it had a strong meaning. And after that, it's not enough. If we really discussing about predictability, everybody should be involved. It's not only about us. Okay, we've done our part now, and I'm very happy that we manage also in the, let's say, second step, to gather all of you, and not only you, meaning authorities, industry, CROs, patients associations. Everybody is in the room when we discuss about the next steps. And I believe that you'll refer also to the Innovation Hub. This is a great experience. It was a great experience. Yesterday we had a meeting. It was much more than I expected. And usually I'm an optimist. Things are really going well. So we have to use this example for our next steps. And we have a lot to do together in HTA field. I think and I hope that by our next meeting next year, we will be able to discuss about a very stable and predictable environment for clinical trials in Romania, and also about the next real steps that will be done by then in the field of HTA assessment. This is how I see things. And
thank you very much. Please allow me to say that I was very happy when I saw your confirmation to this panel, because I think you are a living example of predictability, and I want to also congratulate the fact that you went outside the job description. I will give the example of clinical trials that you mentioned. You set your job, the job of the agency was set from the beginning, but you went that extra mile in putting together and coordinating the efforts to put together all the stakeholders in order to make sure that even in the future, even in the fields that are not under the direct agency coordination, things are going well, and we are moving forward with what you started, as the agency president. So congratulations for that, and I'm sure we'll have the chance to hear from you again in the Q&A session. Next, we have a leader from the healthcare distribution sector, Mr. Iulian Trandafir, who is the CEO of Alliance Healthcare Romania. Mr. Trandafir, how do you see the distribution sector contributing to predictability and resilience in our healthcare system? And before talking about solutions, please allow me to ask about the challenges. Let's explore some of the challenges and the bottlenecks that you see and that you face in your field of activity.
Thank you very much. Good evening, everybody, and thank you very much for having me here. I just noticed from the beginning that in the previous panel there were 6 persons, so there are 50% more there in this panel with predictability and resilience. And I think this is the first message. So predictability and resilience is not so, does not have the weight that the prevention has. Why I'm saying that? Because the health system and the part of distribution and retail in Romania, it was, all the time, it was under a critical situation, more or less. In this moment, we have two main problems that I have to talk about, and which can be very, very important for the future of the system. The first one is the package of law, which are now probably will enter in force in next year. With that 1%, which is a tax on the turnover for all the companies which are turnover with more than 50 million euro. Probably know very well that in the health system there are a lot of the big distributors and also the big retailers, all of them, have turnovers of more than 50 million. But based on the data from the Ministry of Finance, the aggregated profitability is only a little bit less than 2%. 1% on the turnover of the distributors or retailers means that we'll halve the profitability. This means that all the investment will be cut, and probably there will be also other influences on the people which are hired in this system. It is very difficult, just a parenthesis, it is very difficult to reach in pharma distribution or retail a profitability, gross profit of 6.25%, which is around equivalent with 1% of the turnover, in such a way that to say that we will pay 16% tax on the profit. So in fact, we will pay tax on profit almost 50%, which is the highest in the world, as far as I know. More than that, we have the third quarter of the medicines, of the sales, of the distribution, are done by the prescription medicines. The prescription medicines, as you know very well, are the prices are kept by the state. So we cannot use the increasing in price, like all the other industries, in order to cover or to try to recover, in a way, these taxes that are very, very high for the state. More than that, which is normal in a way, for the products which are more expensive than 300 lei, we have a cap of 30 lei in markup, and the pharmacy is 35 lei. So you can imagine that for products which cost 3,000 lei, we have 1%, more or less distribution and retail the same. So all the products that are more expensive than 3,000 lei are not sustainable from the financial point of view. All these products will be probably very hard to be found in the market because nobody will go into a business or into an organization to lose money for that. We have just a high-level analysis of the impact on the patients, so it's not something very detailed, but there are around 65,000 patients which will be impacted by this changing in the law. Mainly patients from oncology, because these are the new molecules and the molecules which are very, very expensive. I'd like to say that each system in the world, doesn't matter the industry, must be financed in a way. It's normal to be financed. In fact, the money in a system or in a business or in everything, in a ministry, in a government, everywhere in a country, it's equivalent more or less with the blood in an organism. If you have enough blood and the blood is healthy, we can go further without any problem. If the blood starts to drain, the organism will start to suffer. So this is exactly what happens these days, when after 10 years of payments in time, the payments were postponed. And more than that, we noticed that the last month that we have the transparency on the site of the National Insurance House was the month of May. And we took the data, and we have a very small analysis, and we realized that the budget that was agreed for this year for the National Insurance House for the medicines was finished in August, comparing with last year when it was finished in November. So again, these are the figures which are officially published on the site of the National Insurance House. If there are some mistakes, are probably done because of that. What we noticed is that in September there starts with big problems with the payments. And because of that, there were normally big problems in the system and big problems in delivering medicines to the pharmacies. Now we are in the situation that we are close with the payments, so they are okay, but in October there was nothing paid. So we don't know what will happen in the future. So in general, I would like to find solution, not to come with the problems. For the first point, with the 1%, I saw three possibilities. The possibility is that the things to remain like that, and I don't know what will happen with the patients. The other possibility is to have some special, let's say, special exceptions in the law for this, at least for these products, in order to be able to distribute them further. And the third one is probably the best one, because it's about a subject which was not touched since more than 10 years ago, is the methodology of price calculation, which we know very well there is a program now in the Ministry of Health, but also we know very well that the conclusion will be probably in the end of next year. So I don't think that we have enough time till the end of next year to recalculate everything, the price and everything. For the second part of the problem with the payments, I think here I really don't know. I'm not a political person. It's just like I'm an engineer, like Cătălin. For me, it's clear that there are two possibilities: to cut costs here. This means to reduce the number of treatments, and this will have a negative impact on the patients, or to increase the financing of the system. These are the only two solutions that I saw to the second problem. I just want to close thanking to Cătălin because he made a call to action with a philosophical touch, in a way, in a very nice way, and to say that probably I will repeat, but in medicine and in health, I believe that it's an investment. And I have friends which said, they used to say, okay, I invest in a car. And I spend some doctors with I spend some money with the doctors in a clinic because I have to pay the... In fact, the things are in the other way around. So buying a car is an expenditure, and spending some money in a clinic, taking care of the health, is in fact an investment in our own. So thank you very much.
Thank you very much, Julian. I think you touched on a very interesting point with the blood stopping to flow. And I think here is a very interesting perspective. We know that in the political arena, now the issue of the payments is being addressed. But it's important maybe to explore what are the effects of this lack of predictability when it happens. So I will propose this also to our third panelist, if that's okay, as a topic maybe. Our third panelist is Mr. Frank Lofer, who not only serves as the general manager of Roche, but also holds the role of president of the local American working group. Frank, please allow me to propose the subject of the predictability of finances and what's your perspective from your position on this, and also what is your perspective on the pillars that we have to ensure as a society in order to have a predictable and resilient healthcare system?
Thank you so much, and thank you to Aspen for inviting us, and thank you for the panelists to spend the time with me here. Allow me to start with the pillars, which I think are relevant, and then I will close with the financing. Thinking about the pillars, we took the liberty with the team to look on the definition of a resilient healthcare system from WHO. So WHO tells us a resilient healthcare system is one that can effectively prevent, prepare, adapt, and respond to public healthcare threats while ensuring quality, essential health services in all contexts. So we have heard in the first panel a lot around prevention, and I think that was alluded to very well. We also heard a lot about preparation, and especially what Dr. Mikashmi said about diagnostic has a lot to do with preparing, because you cannot set up a lab only when the crisis comes. You need to have the instruments, the workflows, and the trained personnel before that, so you have to be prepared. And now I would like to quickly look on the point of adapt and respond. When we say we have to adapt and respond, we have to go back to the point which was earlier made on how quick are we to bring innovation, and I agree with the aspect, it's not only medicines or diagnostic products, also innovation in new treatment paradigms, in new operation techniques, etc., into the market. So how fast are we to adopt the guidelines to the state of the art, which is there, and to make this accessible for the patient? And there, I think, really the President Brisada did a great job in his area of responsibility, and we are much better. Still, we see when it comes to reimbursement, there is a lot of delays. And this is explicitly not only reimbursement of diagnostic and pharmaceutical products, it's also the reimbursement of healthcare professionals offering the state-of-the-art interventions to the patients. We need to find a way that this is done, and I'm sure that Dr. Schenker will also be able to speak to this in the next panel, as he is an expert on it, being scientifically always on the forefront, but then not always being able to have the right environment to bring this to the patient. On the second point I would like as a pillar to look at is the quality health services in all contexts. And we heard this also from a country like Moldova. We need to see where is the majority of patients, and it is rural areas. And we have to find a way on how can we make a healthcare system fit for purpose, not in Bucharest and Cluj and Timișoara, but there where the majority of the patients are. And I also would like to look there on innovation, is also to think about, do we need the patient to travel to the hospital to see the doctor there, or can we have a nurse traveling with the treatment to the patient where he lives and bring it there? So in many countries around the world, we also see a task shift, a smart task shift, where you can then have the precious time of the specialist to focus on complicated cases, on the diagnostic, and then the routine implementation being done by healthcare professionals of different level of education and much closer to the patient. I think also there we can really get more resilient and address not only financial issues, but also the issues we have in a lack of trained healthcare resources. And with the American Chamber of Commerce, we also work on this. And now talking about financing, I think we are making progress. We have with the local American working group and many colleagues which are here with me in the room worked together with the Ministry of Health to look on the innovation program and to say how can we get ways to finance faster the standard of care. At the end, we still see, especially these days while we are sitting here, that a resilient healthcare system with the best policies in the world cannot work if there is not a resilient financing system. If the money is not flowing and if a hospital cannot place a purchase order, there is literally no treatment. And I was just the other day in Târgu-Mureș, and they said for multiple sclerosis patients, we call them to postpone the appointment because we have no medicine in our fridge to treat them, because we don't have the possibility to place new purchase orders. And I think there we really have to be honest. Everyone here in the room did a great job and we did a lot of progress, including Ministry of Health and others. But if the Ministry of Finance is not addressing the way the cash flow is working, we can do what we want, nothing will happen. And I would like to close with a sentence I learned from a dear colleague from Africa. He said, a policy without financing is lyrics. And I think we are often discussing about lyrics at the moment. So we have to get the people on the table to have also the financials to implement them. Thank you.
Thank you very much, Frank. Indeed, you touched on a lot of points, and maybe we can take note for next year's Aspen Summit to also have the Minister of Finance on board for such a panel on resilience, as they indeed play a crucial role. Our final speaker, but then the discussion is just starting, is Mr. Radu Rășinar, the country president of AstraZeneca and also vice president of the local American working group. Radu, you have been involved in a number of initiatives, such as the Health Innovation Hub, and I know you are a strong believer in prevention through education. Can you tell us how these initiatives enhance the predictability and resilience of our healthcare system, and what do you see to be the role of the private sector in achieving all these ambitious goals that we are all discussing?
Thank you, Theodor. I would start, because Frank ending with a kind of a joke, very rightful say, that first of all, I have to salute the whole dialogue on innovation and sustainability. And I think we did very significant steps forward. In terms of strategy, we know better the direction in terms of innovation, and we'll talk more about it. But then, sometimes within or between these good intentions, there are tactics that at least the industry would not understand. And we were, maybe last week or 2 weeks ago, invited for a project to give an input on a project that looks into HTA and pricing methodology review that has no mandate on looking on treatment rates, on how the Romanian treatment rates are below the standards in European Union, that has no mandate to look into the harmonization with the European Union HTA that would significantly change in a year or so. So these are things that we can easily correct and spend the energy into the right directions instead of detouring ourselves from the European pathway. Now, coming back to the challenge in itself, to the subject of today, I'm very proud. And I want to take a second to tell you that we're very proud about the Health Innovation Center that we have built in Romania. And I believe it is a unique one because not only that it follows the strategy of the healthcare, like probably not that many health innovation centers in the world, because they would be parallel to that. It's a central element, or it is designed to be a central element of a modern healthcare system. What? It's like in rugby. Okay. So then the story in itself of our Romanian Health Innovation Hub is unique also because it has the G6, the association of the 6 traditional universities of medicine and pharmacy, being part of the Health Innovation Hub. And what can be stronger than that? You have the best minds in the universities working into the same place with the industry and supporting the strategy of the minister. So the Health Innovation Hub is a fact and exists, and we have already started the first project. We had yesterday a meeting with 60 people, thanking the patient associations, thanking the G6 Academy representatives, the National Drug Agency that is the strategic coordinator of the project in itself, and the industry. And we are looking into a competitive model for clinical trials in Romania that would bring benefits across a couple of ladders. And it was a very intense 7.5 hours workshop yesterday that I have never seen before with such a diverse group, and I'm sure that the outcomes of that would be spectacular. Our promise is that we will continue in the Health Innovation Hub with very pragmatic things. I invite you all to sit in the future projects, to read about them, the ones that are interesting for you, jump in, pay for them, because every good thing is expensive, but the payback would be significantly higher for all of us. That's it. I mean, I'm not sure if you have seen the information on the Health Innovation Hub website, on the log website. Please do so, listen to our communications, and thanks again for all the participants of yesterday. I was amazed. I want to let you with a different perspective. You know, we talk about pricing methodologies and HTAs that are a speech of maybe 10, 15, 20 years ago. And you know, a smart person would not necessarily repeat the mistakes or will try to do better in the future, not necessarily repeating each and every step of what was done, but you take a leapfrog and you try to move forward. The same happens also in sustainability. And I will show you a slide that to me it was very intriguing. You know, I do not dispute the GPs, the primary care physician segment should be of an increasing importance in Romania for obvious things. Their role in diagnostic, their role in treatment, in the non-communicable chronic diseases obviously need to increase. But there is another way of looking at that absolute need. And I'll show you a slide, and I'll let you reflect on a second. And it looks into the carbon footprint of where the healthcare happens and how the difference is significant between healthcare that is given at the primary care physician level, or if you go to a specialist, or even better, if you go and you actually spend time educating prevention directly to the patient. And this one is a new perspective. It was thrilling for me, and I'm sure it will come as a benefit for us if we actually manage to increase the actual involvement of primary care physicians. Thank you very much.
Thank you very much, Radu. Indeed, you left us on a very, let's say, thinking note, because we'll probably have to discuss more about the role of the GPs in assuring a resilient healthcare system, and I'm sure in the discussions we will have that. We still have a generous time for the discussions. Please allow me, before opening the floor, to do a few more mentions. First of all, Frank mentioned the innovation program, which is mentioned in the cancer plan, which indeed I didn't mention after your intervention, but I am doing it now. It's a game changer for patients in Romania, and I think would be interesting to see next year if you can elaborate this in a session, but also to see the progress until next year, because indeed it's a hot topic and it will probably be addressed by then. But it's a thinking topic for all of us. The second issue I want just to put on the table as the moderator. It's wonderful to be the moderator, because you just raise ideas and someone else thinks about them. Is the concept of anti-fragility. Frank, you gave us a very precise description and definition of resilience. And I think it's hard to consider the resilience of the whole healthcare system as a whole, because we see that in situation of crisis, some parts are fragile, some parts are resilient, and some others thrive. And we saw in the pandemic, we were left with parts that we saw that crumbled, others resisted, and some others improved. And I want to bring in the discussion the concept of anti-fragility, introduced in the literature by Nassim Taleb, in which, after a crisis, a system not only remains in good working conditions at the same baseline that it was, but improves. So I want to raise the idea, but first we'll have questions from the audience, and maybe at the end we can address it. How can we improve the parts from our healthcare system, the areas in our healthcare system that are not only resilient, but anti-fragile? And before opening the questions, I want to take advantage of the fact that we have in the room a technical representative of the National Insurance House. And I apologize for putting you on spot maybe with this, but I think it's important, before the questions, to also have an intervention from the National Insurance House, because the house plays a huge role in the predictability of the system. I would like to invite for a short intervention Ms. Julia Stoia. She's a Deputy Director within the National Insurance House. And Julia has been part of the team that worked this year on the updated framework contract and on another number of initiatives contributing to the predictability of the system. Therefore, Julia, could you please present us briefly what are those initiatives of the House that contribute to the predictable and sustainable financing that the House assures in the system? Thank you.
Mulțumesc frumos, bună ziua tuturor. Cred că actele normative care au intrat în vigoare începând cu 1 iulie anul acesta ilustrează foarte bine tema discuțiilor de astăzi, predictibilitate, reziliență și trecerea către un sistem bazat pe prevenție. Pentru prima parte, predictibilitatea, ne-am dorit și am reușit să promovăm și să aprobăm acte normative fără termen de aplicare. Anterior, contractul cadru era valabil doar pe o perioadă de 2 ani, iar normele sale de aplicare doar pentru o perioadă de 1 an. Asigurând acte normative care nu au o dată limită, am asigurat predictibilitatea atât pentru asigurați, care în acest fel își pot cunoaște drepturile fără teama ca de la an la an acestea să se schimbe sau să se reducă, cât și pentru partenerii noștri de contract, furnizorii de servicii medicale, de medicamente, de dispozitive medicale. Mandatul meu fiind unul strict tehnic, o să prezint pe domenii de asistență medicală câteva noutăți care ilustrează discuțiile de astăzi. În asistența medicală primară s-a mutat focusul și finanțarea pe partea de prevenție. S-au asigurat fonduri de 9,5% din totalul alocat serviciilor medicale pentru medicina de familie, iar pentru creșterea acoperirii cu medici de familie în rural, venitul medicului nou venit într-o localitate rurală este cu 50% mai mare decât venitul similar al unui medic din urban. Pentru localitățile în care nu există puncte de lucru sau cabinete de medicină de familie, acest venit este chiar dublu și este asigurat pe toată perioada de contract, pe toată perioada în care medicul este prezent acolo. Începând cu activitatea anului 2024, se introduce și plata pe performanță, care este legată tot de ținte atinse în ceea ce privește consultațiile de prevenție. S-a modificat și structura de finanțare în asistența medicală primară prin diminuarea procentului alocat plății per capita și majorarea procentului alocat plăților pe serviciu. Serviciile de prevenție s-au detaliat, s-au rafinat, s-au modificat în funcție de grupele de vârstă și s-au extins analizele de laborator recomandate în urma acestor consultații. Toate analizele de prevenție se decontează laboratoarelor peste valoare de contract. Nu mai sunt în niciun fel îngrădite de acel faimos plafon de care ne lovim cu toții. La fel, analizele recomandate pentru femeile însărcinate, toate se decontează peste valoare de contract. Și în ambulatoriul de specialitate clinic s-a extins finanțarea, s-au mărit fondurile alocate, s-au extins serviciile oferite. La fel, în ambulatoriul de specialitate paraclinic, pentru investigațiile de prevenție, așa cum am spus, și pentru investigațiile bolnavilor cronici, pentru 6 boli cu impact major. Iar în ceea ce privește spitalizarea, se continuă accentul pe spitalizare de zi, care la fel este finanțată la nivel realizat. Cam atât din partea mea, dacă mai sunt întrebări.
Thank you very much, Julia. I think it's very valuable to have this intervention and to have you in the room, and it addresses also the introduction to the GP topic raised by Radu. Julian, I think you have a comment.
Yes, I don't want to lose this opportunity because when we talk about National Insurance House and predictability, we will need more transparency from the National Insurance House. And as far as I know, the Minister of Health is a big supporter of the transparency. So my question, it will be possible to have on the site some data which are not very complicated, which means the execution of the budget and to the county level, to see what was the amounts, what was paid for the reimbursement system and what was the amount paid for the national programs and what are the last months paid. Because this is the way that we can balance or rebalance or predict the system and what we'll do further. Because in the end, all the system in Romania, from the financing point of view, is supported by the state, by the patients, and by the manufacturers. Because the manufacturers, I have to recognize, are the one who kept the system running, because they offer us a certain payment term, so a certain exposure, which we goes further to the retail and from which the insurance house benefits, which is normal. But it's also normal to have a transparency on that and to see each month where we are, if there are problems, and to see these problems, I don't know, with few months before. This year, we feel it in August and September. I'm not sure that the end of the year will be a happy one, because the end of next year, the calculation shows us that the costs, the budget was finished in November, including November. In December, we didn't receive money last year. Now, the budget ends in August. It was spent totally. And the problem starts to appear. We are in October, 20th of October, we didn't receive any money which were due in October. So I'm very curious, this is the second part of the question, if till the end of the year, the insurance house will come back to pay in normal payment terms, or there will be some postponement to that. Thank you.
Thank you. I'm sure Julia will pass this message to the President of the House. Or Julia, if you want to have another comment on this, please.
Da, mulțumesc pentru întrebări. În ceea ce privește transparența, pot să vă răspund. Partea de buget nu este domeniul meu și n-aș vrea să ofer informații inexacte. Pe pagina de web a casei sunt aceste informații financiare defalcate pe clasificația bugetară, așa cum sunt aprobate prin legea bugetului de stat. Este și o evoluție a bugetului și plăți lunare și la fel pe site-ul tuturor caselor de asigurări, dar pe site-ul casei sunt cu siguranță, le consult și eu.
O să vă rog să-mi spuneți și mie unde anume sunt pe site-ul casei.
Ne uităm pe un telefon în pauză
pentru că,
și sigur.
exact, din luna mai, până în luna mai au fost, din luna mai n-au mai fost. Asta era de fapt ideea. Că din luna mai ar trebui să se continue cu ce era un lucru foarte bun. Din luna mai noi nu mai știm, nu mai știe nimeni. Toată lumea spune am primit bani, n-am primit bani, am primit o parte, n-am primit deloc. Nu se mai știe. Deci sistemul nu este...
Plățile nu sunt defalcate la nivel de furnizor și doar agregate pe domenii de
agregate pe domenii.
I'm sure we can continue the discussion during the break. I don't want to monopolize the discussion on this topic, and we have Julia in the break as well, I hope, and we can discuss bilaterally and figure out this issue. I would like now to open the floor for questions. I do have a few questions, but I want first to open the floor for questions. Dr. Malkin, please.
Thank you, Theodore. And first of all, to be very transparent, I will say from where I am speaking. I'm a French doctor, but I'm seconded by the French government to be the advisor of the Minister of Health. So I'm working with Mr. Rafila in the team. Thank you very much for all the panelists, and for the first session, the second session, which turn around, by the way, around one which is one of the core of the pillar of the health system is financing. Everybody was speaking about progress in technology, innovative mechanism, IA and so on, but at the end, health has a cost. And it's not only a cost, but what was saying in the previous panel, it's an investment. But investment is money. And health will be more costly and costly, whatever. So we see that in Romania, there is a huge problem around this, like in other countries all around the world, in financing. And everything is interconnected. You were speaking about the remote areas, and to provide, as Julia says, she will give an answer from a financial point of view in increasing the reimbursement of the practitioner who will practice in this remote area. So everything is around, not everything, but it's very important. On another side, it's not because you will invest a lot of money that your system will be better. The GDP, the part of the GDP in the United States is 14 or 15%. It's not why for this huge investment that the system is working very well, leaving behind a lot of vulnerable population. On the other hand, in Romania it's 5%, half of the average of the European Union, by the way. We cannot say that it's working very, very, very badly. There are a lot of progress has been made during the last 20 years. But now the issue is you can, from the financing, you can decrease the cost, you can control how the money will be more useful and spent in a more effective way, and you can also try to increase the budget. We know that the national house is underfunded, so it's not the place to discuss technical issue to increase the budget. There are a lot of things we can do, but it's very political sensitive as well. It could be technical also. Better control and all the socio-professional category which are exempted of contribution, and the whether all the population of all the companies are contributing to us. There are a lot of mechanisms. This is on the way. Should be put on the table, even if it's political sensitive, because if not, it will not work, and it will not give the opportunity for all what has been said in the first session, for diagnosis, for better prevention, for drugs as well, which is paying a lot of contribution to this, also to these financing systems. I just want to raise one point. I hope in the next year or in 2 years from now, in the next Aspen event, we will see another player. Now it's there are a lot of brainstorming on this issue. What will be the role of the complementary private health insurance? I don't see anybody here representing this sector. It has been demonstrated in some countries that there is a dual mechanism, a national health insurance, which is for whom is contributing all the individuals or the company, and also as well in parallel, not only in parallel, but in complementary, not only in parallel, in complementary, the role of these private sectors in covering the financing cost of the health. This is just a question I raised here because now the reflection and the thoughts are on the table even in the Ministry of Health.
Thank you very much, Dr. Malkin. Of course, I will give the floor to the speakers if they want to respond to your questions, to your question, but it is not really directly related to the current expertise that we have in the panel, but I think it's indeed a very good topic to discuss for next year because it is an innovative policy, the complementary insurance that we were discussing technically in the last few months, and it is important to take it as a topic. But of course, if the panelists would like to comment on it.
Yeah, I think I can quickly build on it because I like this aspect, and it also links to the clinical trial topic which we talked yesterday, because if you go to many places in Western Europe and you ask the manager of a big hospital, where do you earn your money? What are your income streams? They roughly say 1/3 is public health insurance. 1/3 is private health insurance. The third is industry paying for clinical trials conducted in the institution. So at the end, the salary of a doctor, the investment in a new CT machine, the infrastructure, whatever you have running in a hospital, is only 1/3 coming from the government, and the other 2/3 are other income sources. And I fully agree, the more we allow also public healthcare providers to be more diversified in the way they generate their income, the more resilient the system will get. And if this is now 1/3 each or another share, doesn't matter, but we need to open this up so that it is more balanced and that we also have a cross-fertilization in the sector between out-of-pocket spend, private insurance, and public insurance. And that we not have, and I agree with you, the US is not a good example, because the rich people overpay in their own clinics, and nothing what they do there is basically benefiting others. So therefore, the more integrative we are in the sector to also allow public hospitals to access these different sources, the more resilient we will get, and the more balanced the financing is, and the less investment we need from the house and other government funding. So I think that's definitely an important aspect to further discuss and see how Romania can catch up in this direction.
Radu, did you also want to make a comment? No. We have only a few minutes left, and before closing remarks, please allow me to open very briefly a topic that's very dear to my heart, and it was also mentioned by Professor Rafila in the morning, the topic of human resources. Dr. Natasha Zopardi-Muscat also mentioned that in the future regional committee that will happen next week in Astana, a resolution on a framework on health and care workforce will be adopted, and I'd like to say that Romania was at the forefront of drafting this resolution, which is it's for the first time when this happened. And in the last few years, since the Bucharest meeting in March, when we adopted the Bucharest Declaration on Health and Care Workforce, Romania has been internationally leading, at least in Europe, the topic. So please allow me, taking the liberty to keeping the discussion open for only 2 more minutes, to open the discussion on health and care workforce. And in your fields, how do you see how the workforce should look like in your fields in order to make sure that they contribute to the predictability and resilience of the system?
Now, if you allow me, because probably I'm the most interested in this subject, until artificial intelligence will be able to take our places, I really wait to take my place first. We need to see and to take care, that's the main message. First of all, we need to take care of our own people. And I had a few personal experience in the agency in the last days, looking, and maybe too much looking at and trying to bring new people and trying to engage as much as possible and to foresee what's next. And for that reason, sometimes skipping or not paying attention to the people that we have, that we already have, that are really working 10 to 11 hours per day, and I'm not exaggerating, in this period in the agency. So I had a discussion with one of my employees, and for me it was enlightening, saying, oh, I totally get it wrong. I need to pay more attention to my people, the one that I have, and to be as careful as possible to keep them there and to make them as much as possible satisfied, if this is possible in the public sector, because they are really my main resource. And after that, okay, we can build on. Those are messages, financing, okay, it's about the system, about the legislation, about everything, but let's try and take care of our people first.
Thank you very much. I think it's very valuable to end with this topic, because we tend to speak a lot when it comes to human resources about doctors, nurses, but we forget the pharmacists, we forget the people that work in the public sector, in healthcare, and they are very important. I know you are struggling and making great efforts at the agency to bring new people, new blood in the system. With this being said, I've been informed by my colleagues from Aspen to inform you that the coffee break will take until 12:15, so we have 15 minutes. And in the last 1 minute, which I still want to pose a challenge to our panelists, I will end here, and thank you for being here, but I will pass the mic to all the panelists for one sentence, a closing remark, and a closing message for this panel. Thank you all. Julian?
Thank you. One sentence is too low, but let's say like that. We know that we have problems. All the health systems have problems in the world. All systems probably are sub-financed, but at least let's be more transparent on that. Let's be more transparent and let's give to the actor in the system the possibility to create some plans for the future, at least for the following months. Thank you.
What could I say about predictability is that I predict that we will see each other 1 year from now, and we will have more things to discuss, maybe not the same ones.
Thank you. And I think we have a year of elections. So 4 elections coming up, and all of us have a vote. So I invite you, vote for health when you make your decision.
I'm still under the strong impression of yesterday, and I want to take this opportunity to thank each and every of the people that were participating in the 7 hours and a half workshop of yesterday. Thanks a lot. Thank you.
Thank you, and enjoy the coffee break. And we'll be back here in 15 minutes for the next panel.
Hello, everyone. My name is Stefan Strilciuc, and hoping everyone outside has gotten a chance to get their caffeine levels in check. We are ready to start the following panel on supporting the implementation of critical national strategy, specifically how we can ensure that national plans for combating cancer and strategies for cardiovascular and cerebrovascular diseases can be supported. And in this respect, I am honored to host these panelists in front of you who are probably uniquely positioned to speak on the matter at hand. And with us we have Dr. Cristian Bușoi, the chair of the Industry, Research and Energy Committee in the European Parliament, also a chair of the Challenge Cancer Intergroup, the same institution. Dr. Michael Schenker from Craiova, who is the head of the Oncology Specialty Commission in the Ministry of Health and one of the people in the front line of the National Cancer Plan. We also have with us Mrs. Mihaela Joana, very active patient representative who has been spearheading efforts in the field of cancer. We also have industry representative, Mr. Lucian Besnea from Medtronic, Romania. And also online with us, we have two important speakers. One of them is my colleague and friend from Cluj, from Iuliu Hațiganu Medical University, Professor Dafin Mureșanu, who is the head of the Neurology Commission of the Ministry of Health and the president of the European Federation of Neurorehabilitation, and Dr. Thomas Hofmarscher, the research director of the Swedish Institute for Health Economics, and how important health economics is in this discussion, as we've seen on the financing discussions that have taken place in the previous panels. So, without further ado, maybe just to say a couple of words, Romania, Europe, and the world, perhaps, as you've seen, is in the era of strategies and plans. And that's very good. But also, the scarcity in health is ever present. We have unlimited needs, and no country is able to meet them. So I think in this context, it's very important, as we hope that today the national health strategy will be approved. How do we maintain the prioritization of these areas without cannibalizing other important areas in the health system? How do we ensure that these strategies collaborate one with each other so that the maximum benefit is gained by the population? So we will respect the format as until now. I will introduce the speakers to have some initial remarks, and then I want us to try to really stick to the Aspen spirit of, well, maybe not fighting or disagreeing, but bringing forward the main contention points, and maybe we try to deep dive more in the technical side of the issues during this talk. So we have industry, we have patients, we have the authorities and the people who are technically involved in all these plans. But of course, as in the previous panel, we saw that sometimes it's essential, it's very important that the European level is giving us a nudge in the right direction. And I think the success story of the clinical trials was heavily reliant on this, as the EU adopted the clinical trials regulations. So to give us more insights on what is happening on the European stage and the EU Beating Cancer Plan, I invite Dr. Cristian Bușoi for opening remarks.
Thank you so much, and congratulations for the initiative. Indeed, it is very important to look a little bit closely where we are, what we achieved until now, and what we need to do in the future. And the topic of this debate is very much presented also in the European institutions. Maybe less the Industry, Research and Energy Committee, but the Intergroup, Cancer Intergroup in European Parliament, and SANT subcommittee that maybe paves the way for a full health committee with the legislative powers in the next European Parliament mandate are discussing very much cancer, EU Beating Cancer Plan, the cancer strategies, and also the need to have better plans in the cardiovascular disease area. Actually, my journey with the Aspen Institute and Fundația Renașterea is closely linked with the cancer strategy, and Aspen Institute was among the first discussing the need to include cancer policies into national health plans. Starting from EU Beating Cancer Plan, we have now a very good national plan for cancer. Of course, we need to adapt it permanently. We need to see how we can have the objectives aligned with the reality and what is feasible to be done in the coming years. Clearly, I think that we need to deliver, but it's important that we have the national plan. It is important also to complement it with the right financial support, because the political will is very strong in Romania, from the highest level, the President of Romania, Minister of Health, of course, the Parliament of Romania, the representatives in European institutions, but we need to see how we can translate the plan and the objectives into clear working program, yearly working program with the necessary financial support. And I was very attentive to the previous debate, and I understand the concern of different stakeholders related to the budgetary situation. Indeed, we will face in the coming months and next year one of the most difficult period looking to the budgetary constraints. We need to respect the deficit in order not to have surprises with European funds. In the same time, we should continue to fulfill the needs, and healthcare should remain a priority. And this is something that we should assume and work in this direction. I will not insist very much, you know well, because you are very much aware of the fact that cancer is really a priority for European Union and will remain in the coming years. I believe that with EU Beating Cancer Plan, with the national cancer plans, European institutions delivered until now. Of course, the plan should be improved. We have to remain ambitious, but starting from the EU Health Program, EU for Health, a program that I know very well because I am the responsible person in European Parliament for that, where special attention was given to cancer, to pediatric cancer, to palliative care, to synergies with other instruments. Going then to the Horizon Europe, the research program of the Union, where the mission for cancer is maybe the most important missions, is the only one, or the most important in healthcare for sure, but also among other missions. And this is something that I'm very proud of, because I also tried to contribute to this. The cancer registries are becoming more and more a reality in many European countries. I hope soon in Romania, because this will help us very much to organize better the resources and to have a better image of the needs, and especially the pediatric cancer registries that are special objective of European strategies. Then, of course, what is also very important, beside the need to have access to treatment, to have a better access to innovation in Europe, and this is one of the main objectives of the pharma regulation and directive, pharma legislation that is now under revision in the European Parliament. It's also the prevention. And here the situation is different. Some member states, of course, have better success stories. Some other, due to the scarcity of resources, are not very much performant on this. But in a very good dialogue with patients, cancer survivors, scientific and medical societies, research institutions, think tanks, industry, extremely important, policymakers, leaders, civil society at large, I think we can contribute to raise awareness about the necessity of better prevention, and also to allocate the necessary resources. Indeed, the main need is for treatment, for investigation, but we should not forget about prevention, and this will help us on the medium and long term. Finally, regarding the cardiovascular diseases, I believe that we need to be aware that together with cancer, it is the leading cause of death worldwide, or also in European Union. The access to treatment improved very much in most of European countries. Still, there are inequalities as everywhere, and here it's our duty to reduce inequalities between Romania, between Central and East European countries, and the other European, Western or Nordic countries. Also here, WHO recommendations are very valuable, and we can really involve them and take into account when we develop the European and national strategies. We don't have something similar to EU Beating Cancer Plan for cardiovascular diseases. We have several initiatives at the EU level. As in Romania also, we don't have yet a national strategy for cardiovascular diseases, but the distinguished and excellent experts that we have, Dr. Schenker and of course then Professor Mureșan, will explain us a little bit more about what is urgent to be done and how we can start really to implement and take advantage of the strong political will, the European momentum where the support of European institutions is very strong, as much as European institutions can do, because healthcare is still a matter of subsidiarity, but the support, the political will there is very strong. And also, after COVID-19, the society, the public opinion is open to understand that we need to invest more in healthcare. But we need also to deliver and use all these opportunities. Thank you.
Thank you so much. I think you really touched upon the complexity of the issues we're dealing here. It's not only a matter of prioritization, it's also a matter of all these moving bits and pieces and having to juggle all of them at the same time, such as the health technology assessment regulation, the layer at the European level, and what we will have to do at national level, pricing for drugs and making these more accessible and affordable. I think, thinking about the discussion about the square, Mr. Jonna mentioned yesterday the 4 Ps, 2 private and 2 public. I think we can acknowledge the importance of having another square in this policy setting arena. Local governments, out-of-borders governments and representations such as what you are doing for Romania. Also, involvement of academia, but more importantly, the bottom-up initiatives that are occurring in our country that are already doing a lot in these fields, regardless of the things that are stated in the strategy. So thank you very much for your leadership at European level. And switching gears to the more local environment, I'd like to invite Associate Professor Schenker to tell us more about what has been done and what are the immediate next steps, what are the aspirations in the implementation of the National Cancer Plan, acknowledging that this is not something that can be done overnight. But I definitely saw that a lot of progress has been made, so please tell us more about that.
Thank you very much for introduction, Stefan. Yes, Romania has a national plan for cancer control, and we can say this is a clear strategy for prevention, early diagnostic, specific treatment and palliation dedicated for cancer patients from our country. This is the first plan for cancer control since the last 30 years already, and contain a set of measures that currently are under implementation. There has been done some steps, I may say important steps for our patients, because As you probably know, we already finished the work with all that it is necessary for the program of genetic testing for all the medication that are included in the national program of health insurance company. So every medication that it is used for treat our patient and has a genetic testing mandatory before using this medication. There is also a genetic test, a molecular test that it is free of charge and is paid by this program. Also, in the program for radiotherapy, it was included a new technique which is already used in other countries for some years, stereotactic radiation. And for now, also our patient has access for this kind of technique, which is a big step forward for specific treatment of cancer. Also, liberation of access to PET-CT is another important measure that already has been done, and many interventions, as a previous speaker said, for the screening and early detection, the majority of this being dedicated for the primary care physicians. So these are very concrete and specific measures that has been done for our patients and has direct the patient has access from now on. So also another set of measures are currently under working. It has been published already an order related with the services for psychology dedicated for our patients. This order has been published in September, at the end of September. So in this order are fundamented the principles for psycho-oncology. We didn't have this regulation until now in our practice. Also, the specific services for psycho-oncology are stated there. So the next step is to for the health insurance company to fundament the price for these services, and probably with the next contract we will have some specific service for psychology dedicated to our patients. It is to note that our patients already have access to such services, but are not differentiated by complexity and by the time necessary for each of the services and so on. Also, has been already in the transparency section for legislation on the website of Health Ministry, the order for a plan of action for the hierarchical classification of center dedicated for children cancer, for oncopediatry. And also the order for completion, the older order for palliation services. Also, there is another important set of measures that complete the older order, and also it's very important, and this order was completed by a specific task force conducted by Professor Moshu and Professor Poroch. Also, we have just completed another two important set of measures included into another orders related with first of these two set of recommendation for diagnostic of cancer. The first one, in which are included specific procedures that must be followed by any physician involved in cancer diagnostic, primary physician or specialist physician, no matter. And another order which is which presents some standard formulary that will be used for report of the pathologic examinations. So all the laboratory from the country laboratory of pathology, of anatomic pathology, will report in the future the same kind of reports. This is an important objective, and I hope that we will complete this task in the next months, because for all the diagnostics, for all the type of cancers, because it is very important that in the whole country to be a homogeneous language and homogeneous type of reports and so on, because this is a very important lack of and important needs for this moment. Also, it is almost finished another order with the cancer pathway for the majority of diagnostics for the majority of cancers. This is an important order also because define the pathway for the specific cancers, and all of these orders that I have speak of them will be used for the cancer registry. The work for the cancer registry already started. Also has been published an order with the new report form for a new case of cancer. This has been published in Monitorul Oficial with 1 month ago, and as I know, the preparation of the papers for the public licitation for the IT company that will work to this project is underway right now. So I think we done some steps for implementation of the national plan. It is important to note that this plan contains measures that must be implemented. We cannot produce paper and leave the paper by themselves, because this is not the objective. The objective is to change the what is to be changed, and to make everything that can be improved for our patients with all of the efforts.
Thank you so much, and thank you for guiding us on this path. Maybe before moving on, just to afterthoughts after your ideas. So I grew up in an oncology hospital. My father was manager of the Oncology Institute in Cluj, and when I went from school, I did my homework there just to spend more time with him. So I just want us to reflect, because it's very easy to say there's a lot of work ahead of us indeed. But let's just all reflect in this room what has happened in the field of oncology in the last, let's say, 2 decades. Some of it is, of course, general progress, but I have very vivid memories of the types of challenges and barriers patients, doctors, even industry were facing at that time, and the type of efforts that were required just to try to pierce through standards of care which were more, let's say, or very less flexible. Now we try to speak about the second big killer in our country and societies in general, cardiovascular diseases, cerebrovascular diseases. Of course, this discussion shouldn't be only about that. We can discuss about diabetes, we can discuss about other strategies, because the point is to see how we can collaborate. But because this is highly anticipated, it was announced some time ago, and yet there are not many details about it, I invite Professor Dafin Mureșanu to give us a blitz overview of the state of development of this strategy and what are the immediate next steps.
Thank you very much, Stefan. I hope everybody is able to hear me.
We hear you well.
Okay, excellent. First of all, congratulations for focusing on essential elements of our life and also for keeping us closely together. How shall I proceed? Because I can share my screen eventually, or if you have another way to use my presentation.
I think you can share your screen.
Okay. Now let's do that. Okay, so is this visible so far?
I think colleagues from the technical department are confirming that it's okay. Yes, please proceed.
That's great. So indeed, our discussions and our actions are extremely illustrative for what we are doing, and I think we have done progresses on all sides in this respect. What I would like to do in the next minutes is to put a little bit of focus on these extremely important elements of cardiovascular and cerebrovascular related diseases. And I believe we nicely started 1 year ago with very clearly expressed intentions, and now we are able to have the first draft of consultations, and this is a very important progress that we have done. Considering this, what I would like is just to briefly to recall the idea that cardio and cerebrovascular diseases, it's something terrible. If we look
Apologies, maybe if you can put in full screen the presentation, please.
Sorry, here we are. We are in the full screen.
Great.
We are in the flu blow problem with this burden, and if we talk in terms of Delhi's, we see that if in the Western countries there is a certain balance between stroke and neurodegenerative disorders, particularly dementia, as we go more towards east, we are able to detect that stroke is getting prevalent and more bold. And if we go to our region, we are almost devastated by the 62%, which is terrible. So this is a very, very serious matter. And if we put together with this piece of information, this data telling us that in respect to avoidable mortality for cardio and cerebrovascular disorders, Romania it's in a very bad position. Actually, it's leading from the backward. So it's terrible to see that we are not able to manage these avoidable paths. And our efforts are going towards this direction, actually. And in order to illustrate that, and we know it's a notorious fact that cardiologists are generally doing better than neurologists, and even regarding cardiology, we are not very proud, and there are white spots, as you may see, different spots in our country, particularly in the northern part of Romania and Bukovina, and Oltenia, and also Moldavia down. There are definitely white spots with very, I would say, shallow capacities to manage the cardiovascular related aspects. So our vision is to definitely go towards a comprehensive approach with cardio and cerebrovascular burden, and to take in consideration all the elements that are creating, I would say, a solid frame. And considering the burden that I have been discussed and the evidence that we have, and also the scarcity of resources, actually, whatever we can create in respect to new capacities and to new resources, that will be a perfect blend. And this is actually the direction and the way of our vision. Of course, our national strategy, it's not created in vacuum. We are very much related to the frame of national strategy. Actually, we are acting step by step into this strategy, and we position our cardiocerebral strategy based on this strategic objective, which was nicely developed in the general strategy, optimizing care delivery for major public health problems. And the target is, of course, directed to lowering burden of non-communicable diseases with a major negative impact in the public health. So this was nicely defined from the very beginning. And again, also the national strategy is not acting in vacuum, but very well coordinated with at the European level. And as Dr. Bushoi mentioned, and congratulations for his efforts, and whatever he's doing very consistently. You know, at the European level, it's a clear frame delineating this diseases initiative regarding non-communicable side. We know, and it's clear, that the neurological, cardiological disorders are a leading cause, diabetes, respiratory diseases, mental health, and other neurological disorders. Actually, the mental health, it's a high priority. Mental health is still a large blur concept, and we have to do a lot for that. But we are acting in the very concrete frame of vascular disorders. So therefore, everything was tailored in this direction, in tune with Europe. But Europe was also in tune with the global approach, as a plan for prevention and control of non-communicable diseases was developed by WHO. And as you may see, we are building upon, in a very nice topologic way, and integrating all levels from the global, European, and national. And I think we are very happy to have the support of course, our societies, Cardiological Society and Neurological Society, together with the Minister of Health, our President, Parliament, under the auspices of Romanian Academy and in cooperation with other societies. We have a very generous, let's say, group of support and developers. But what is most, maybe it's very important to be noticed, is that maybe for the first time we have such a large international support for our initiative. And last year in October, our plan have been endorsed by the World Stroke Organization, later on by European Stroke Organization. From the very beginning, European Federation of Neurorehab was with us, together with World Federation of Neurorehab, European Academy of Neurology, and from the side of cardiology, I would say maybe all relevant organizations and societies supported our plans and our strategy. And I believe that this is to be mentioned. Yes, we have an enormous support in this respect. And this was validated generally. Now, coming to the points, because it's time to present some results, we have to put some very good flesh on these bones. And I believe that an executive summary that will start the table of contents, look at the table of contents, the structure of our strategy. I don't want to go through all this and to define this, but you may have a look. What I believe it's mostly important is that we'll focus will come from all sides: infrastructure, human resources, clinical instruments, and of course, as we mentioned here in a very repetitive way, health policies. And of course, if we look into the areas of interventions, we may see that we touch upon all potential elements, from human resources, training programs, preventing brain drain, infrastructure. We focus a lot on acute stroke units, and of course, we focused, and I'll come back to you regarding I would say, the most burning point, which is dedicated to thrombectomy. Pre-hospital care still stands as an important point. We focus on the clinical tools, and we put a lot of emphasis on all clinical guidelines, relevant elements, reimbursement protocol, and so on and so forth. Of course, health policies are enormously important, as funding mechanisms should be contemplated and should be defined. Public health programs, they play an essential role in this respect. Just for the illustrating purpose, looking to the way in which it's organized, so it's a very articulated strategy, defining clearly the objectives. And of course, you may see here OG2 section, talking about measures, indicators, and so on and so forth, funding risk.
I'm sorry, we are not seeing that particular slide, Professor Mureșanu.
I don't know why.
It's
yeah.
frozen. The screen is frozen, yes. And in the interest of time, please.
Okay, good,
yeah.
good. I thank you very much for drawing the attention on that. As for the illustration, I was just putting this example of this section, trying to create a very clear flow and very articulated, I would say, structure in all respects, from objective to measures to indicators, funding resources, and so on and so forth. The structure is based on that. This is just a small section to illustrate what's going on. I can see from time to time the screen is okay. Now, regarding the general objective of our strategy, we are running through, I would say, the whole structure, from the integrated health information system to integrated framework for prevention, early detection, diagnosis, treatment, and monitoring. Then we focus a lot on improving acute treatment in cardiovascular and cerebrovascular, and I want to draw attention that we treated these two elements separately because there are a lot of specificities and a lot of differences between cardiovascular diseases and cerebrovascular diseases. But if we go to the OG5, you may see that in respect to rehab, where we have a real vacuum in Romania, we have created a common backbone to move things further in a tandem with cardio-neuro. I think it's important to mention the training, specialized human resources, and I will come immediately back to you highlighting this. And of course, research, development, and innovation, it's at the very heart of the strategy. Now, what's really up? Because as I presented last time, we promised to have deliverables along the way, and I think we were able to do that. And I will skip the complexity of thrombolysis and how much has been done in this respect, and I think we have done a lot. But I will look into the endovascular procedures for stroke in thrombectomy.
Sorry, the screen is frozen again. At the general objective slide.
Okay, now.
Yeah.
Here
yes,
we are.
Yes.
Yeah, I have to give always double click. It's something interesting. Okay, talking about thrombectomy, the good news is that we have already a new center in Sibiu doing that. We are preparing to launch the center in Cluj, and this is very important. As you may see here, we had some developments along the way, but we are way better with the thrombolysis, and we have to counteract this, I would say, this delay regarding thrombectomy. And now, basically, the whole frame, it's structured on the Stroke Action Plan for Europe. We are partners of these initiatives, and I'm very happy to mention that our minister endorsed the European project, and not only endorsed, but contributed to the developments. And I think we are one of the most active countries in Europe pointing towards these needs to reduce the absolute number of strokes by 10% and to treat acute patients. Almost all, I would say 90% of our patients should be treated in acute stroke units. And of course, then to have a national plan for stroke being articulated in the chain of care. And we need these multi-sectorial public health interventions. And I believe we are very well positioned in this respect. In the same vein, discussing about what we have done, as you may see on the right side of the screen, we are already on the air. We launched this important project, specialized complementary studies of interventional neuroradiology, and Professor Jana is already organizing the content and the program of this neurointerventional part, with a large and general access of radiologists, neurologists, neurosurgeons, interventional cardiologists, cardiovascular surgeries, and vascular. You can imagine that is for the first time when we have such a large community supporting that. Another important achievement, and I think this is very important because it was nothing there, is the priority actions for early post-stroke neurorehabilitation. We have a new priority action, totally new, not overlapping and not jeopardizing and not cannibalizing with the resources of the previous one. And we feel that we are much better. And eventually, if you go on the website of the Ministry of Health, you will see that we are there for the public consultation already. We focus also on the very important part of public health campaigns. We have detected these needs to improve the awareness according to our studies, and I have to highlight here the contribution of ALIA, a very nice important association who's doing great together with us. We have detected this huge delay from the onset to emergency call because persons are not clearly, I would say, in their mind with what the stroke is. 185 minutes, it's a lot. We are a bit better, but still not best in the frame of defining the time from emergency call to the hospital, 83 minutes. And I think we can do a lot on these sites with our partners like ALIA. Further on, another important achievement, and this is really new, and we have here Stefan as a moderator, but Stefan is acting also actively based on this important program of virtual reality-based stroke rehab together with me and with a very prestigious international group in the frame of Neurotech EU. And we are supporting the Ministry of Health with these plans, and I think I'm coming to the end. I just want to close my presentation, inviting you to contribute to our frame and our national strategy. Yes, screen is moving.
Yeah, and thank you for concluding.
Yes, I'm concluding now, and I would like to invite everybody to contribute to this. You may find there a dedicated section for consultations, and please be sure that your recommendations are concise, relevant, and constructive. I think it was important. This is my last slide, and I think we have to admit that we have done a lot, and we have deliverables already achieved, and we'll be ready probably by the first quarter of next year. And your active participation and feedback would be very much embraced. Thank you very much, and sorry for these technical mismatches and the delay. Thank you.
Thank you, Professor Mureșanu. And I'm sure there will be a lot of questions on this topic, but moving on, I must say I am a neuroscience guy, so oftentimes us researchers are very siloed in our areas of activity. I haven't been a lot involved in oncology, despite having background as a child in this area. And when I looked up our next speaker today and what the Renașterea Foundation is doing, I was amazed of not only the amount of resources, but the traction that this type of organization has been able to gather. And I want to invite Mrs. Mihaela Joană to tell us more about their activity, what they have to offer, how they can be supported to enhance these national strategies. Thank you.
Hello, thank you very much. Hello, everybody. Renașterea Foundation was started in 2001. Our purpose is to promote women's health, to improve the survival rate, and our target now is to bridge the gap between the survival rates in the EU countries and in Romania. I'd like to also say that the National Cancer Program is a huge step ahead for Romania, and we are looking forward to getting involved and helping in promoting parts of this program. I'd like to mention the access to HPV vaccination, which we think is very, very important. And it will start December 1st for girls and boys, which is also a big step ahead, up to 19 years old, and it's compensated over 19 years old for women. The screening programs are programs that we would like to focus on. The cancer registry is important, access to personalized therapies, and we have to mention the quality of life for patients. Renașterea Foundation leads EU Commission finance project called Rethink HPV Vaccination. And we will make a study on how the previous campaigns for vaccination worked, or more precisely, why they didn't work. We'll make a study on fake news and ways to correctly inform the public. We'll develop a training methodology and a digital platform that will be available for Romanian community leaders, but also we will share it with the countries around us. And I'd like to mention a screening program that was very successful. It's a ROCAS Sud Muntenia program that we were partnered with Fundeni Hospital. It was led by Professor Cristian Gheorghe. And I think this is an example of a best practice in Romania. As we know, colorectal cancer is number 2 in terms of mortality, cancer-related for women, and number 3 for men. This was a first, this screening project. The target was to reach over 50,000 people to do the FIT test, and we did that. We reached that target even ahead of the deadline. And what I want to mention, it was an efficient management, very good communication campaign. We had a very good cooperation between a public state hospital, NGOs, local authorities, and the public, who was very responsive. And I think this is, I only mentioned this program because it's a proof that we can join forces and make these screening programs and all the, wonderful initiatives that are being made, we can make them successful. And as an advice or as a proposal, I cannot stress enough how important communication is, how we manage to get the message and the access they have or they could have. We were talking about heart diseases. There's a lot of education that we need, a lot of information that we need to provide to the patients, and that communication needs to be targeted to the level of education, to the level of understanding for professionals, for public, and so on. And I also have an observation in the EU funding, for example, for the ROCAS program, we had a 50% target of patients that were vulnerable populations. And we see now in the new projects that is 100% vulnerable population. And my point is that we need to have access for everybody, not only for vulnerable. We should encourage them, but everybody needs to have access. From our experience, we're running a mobile unit for the last 15 years that does mammography and pap smear test in rural areas and in small towns. The mammography system, the information is sent to our medical center in Bucharest and is read by medical doctors, radiologists in Bucharest. So the doctor doesn't need to be in rural areas. And we're very happy to see that now Iași runs 3 mobile units, Cluj is running mobile units, and the screening, national screening program for breast cancer provides for mobile units for rural areas. So I think we should use the technology, we should use the digital access that we could have to leapfrog and get our mortality rates where the EU rates are in the near future, hopefully. Thank you so much.
Thank you so much. Just a quick comment, based on what you said. I remember in my short stint at the National Health Insurance House, my then boss, an Aspen fellow, Adrian Gheorghe, asked us to look up what are the interventions, like the silver bullets, although we know there are no silver bullets in health, but what interventions get the best bang for your buck in terms of investment in health? And one of the things we went and we would try to develop, but our stay there was very short, was the FIT test indeed for screening colorectal cancer. And the fact that you managed to pull this off as a bottom-up collaborative initiative is indeed remarkable. So thank you so much for your efforts. And it leads us naturally into the discussion about cost effectiveness. I'd like to invite our next panel member. But before that, news just came in. National Health Strategy has been voted, so maybe a round of applause for that. It's good to always be aware of what's going on. So, Dr. Thomas Hofmarscher, I know you've prepared some brief slides for today, but maybe before that, just to capitalize on the fact that we are here with us, I was yesterday in Poiana Brașov with Professor Zoltan Kolo, who is helping the ministry now devise a new health technology assessment methodology reform. And one of the discussions was about Sweden, who is one of the only countries, to our knowledge, who is adopting this societal perspective in health technology assessment. And I was curious to see your perspective on this, how approach apply for what's going on in Romania, if at all. So, go ahead, please. Thank you.
Hello, everyone. Thank you very much, Stefan, for this opening question. I'll try to address it towards the end of my remark. Happy to talk about this. But thank you very much for the opportunity to be here today with you, at least virtually. I'm really very honored by this invitation. And so I would like to say a few words also and echo a little bit what the other speakers have already been talking about in terms of national cancer control planning. Trying to share my screen now. And I have just 2 slides really. So what I'd like to do is really to give you both sort of a European perspective and then talk specifically about Romania, because we have been doing some research recently on Romania, and I will also try to address some health economic aspects. But I'm switching slides now, so I hope you can see my new slide. Yeah.
Yes.
So my first key message is I think that history, if we look back a little bit, has taught us that governance of cancer control is really important to make a difference for patients. And as you know, cancer is the second leading cause of death in Europe. It's also the second leading cause of death in Romania, and it imposes a significant economic burden on our societies. In one of our publications, we have shown that the economic burden of cancer in Europe is 199 billion euros per year. In Romania, our estimations show it's 1.6 billion euros per year, or 83 euros per capita. So given this huge burden, both this disease burden, the economic burden, I think it's good news that the importance of addressing cancer has reached the highest political levels. So in the EU since 2021, as Dr. Bushoi said, we have the Europe's Beating Cancer Plan, really launched by Ursula von der Leyen, the president of the Commission. And then also the good news from Romania that in the beginning of 2022, your own president, Klaus Johannes, launched the Romanian national plan to combat cancer. So the political commitment is there. And what's also there is the fact that, we want to try to address cancer in a comprehensive way. So on this picture here, you see the 4 pillars of Europe's Beating Cancer Plan. So we should focus at the same time, should focus on prevention, but also on early detection, on diagnosis and treatment, and on survivorship, because we need all of that to reach the goals of reducing the risk to get cancer, but also improving survival and improving quality of life for patients and survivors. And then there's also these cross-cutting aims, like supporting research and access to innovation, reducing inequalities in access to cancer care. And that's, I think the good news is also this is very much reflected in the national control plan in Romania with its 11 priority areas. So the good news is that there's political commitment. But my second message is really that commitment is not enough. And I think that's what Dr. Schenker has already said in his presentation as well. Drafting the nice plans is good, right? But that's just a prerequisite. We really have to turn the aims that are specified in the plans into actions. And some research that we did earlier this year was actually to, at the Institute, is to develop a dashboard, a cancer dashboard for Romania, in order to support the implementation of the national plan in Romania, but also more generally to monitor a little bit developments in trying to improve cancer care, the quality of cancer care in Romania. So the end result was this nicely color-coded table. Usually I'm talking about numbers, but when you try to address a wide audience, sometimes it's easier just to show colors. Red color meaning not so good, yellow sort of in between, and green meaning a positive development or a positive status. And what we did, was really to start from the top, try to talk about or analyze what is the current state of the governance of cancer care, because as I said, that's the prerequisite. And in Romania, we see this positive development with the National Cancer Plan, and just now also the National Health Strategy, which will help to focus on prevention. So that's excellent. But when we then talk about the disease burden of cancer, this is where we see, the big challenges. We all want to achieve high survival rates. But unfortunately, in Romania, the survival rates of cancer patients are below the EU average and mostly among the lowest of the EU member states. But we do see, on the other hand, a positive development, which is why you see that there's a red color for the status quo, but there's a green color for the recent development. So things are improving. They are moving into the right direction, but it's going slowly. And we also have then some indicators that really try to cover these 4 pillars that I showed you on the slide before. So they try to cover prevention, early detection, diagnosis and treatment, and survivorship, and just some selected indicators that we thought are powerful to think about. And prevention, it has already been mentioned, for instance, the HPV vaccination, which was, I think, initiated in Romania already in 2008, but the vaccination rate has always been less than 2%, like extremely low, unfortunately. But now with this new development, 1st of December, HPV vaccination being reimbursed by the National Health Insurance House, and also being available for both boys and girls. I mean, this will hopefully help to turn the tide. in this area, and that's also from a health economic perspective really a good return, because it's cost effective, and in the long run it might even be cost saving actually, but of course it requires upfront investment, and that's generally true for everything that we do in the area of prevention. Early detection, here we picked two examples. We picked breast cancer screening, cervical cancer screening. And for breast cancer screening, of course, you have now some pilots that have shown some promising results, but the implementation of a national breast cancer screening program is still lacking. So right now, I mean, there are very few women really that are getting screened. So the outlook is positive, but at the moment it's quite bleak. And the same is true for cervical cancer screening, where you already had a program since 2012. But the participation rate is really the lowest in the EU. So there's still I think lots to be done, lots to improve. But early detection again is a very important area to focus on, because if you look at breast cancer, for instance, that's the biggest cancer type among women. If you catch cancer early in stage 1, you have an over 90% chance to survive. 90%. If you catch it very late in stage 4, your chances are less than 30%. So 90% against 30%. And at the same time, the costs of treatment in stage 1 compared to stage 4, in stage 4, they are 3 to 9 times higher than in stage 1. So by catching cancer early, you're not just improving the survival chances of patients, but you could also save money for the healthcare system in terms of treatment costs. And then also in terms of indirect costs. So from a societal perspective, we would even benefit more if we take into account indirect costs in terms of productivity losses due to sick leaves, premature mortality, and so on. For the diagnosis and treatment part, we focused on the very basics because in order to deliver care, you need human resources, qualified medical personnel, so you need the physicians, you need the nurses. There has, of course, been a huge brain drain from Romania to other EU countries and the UK. In the past, it's starting to stabilize, so the numbers are starting to look better in some areas, but that's of course still a challenge because the number of cancer patients is growing, so you also need more qualified medical personnel to take care of the growing number of patients. And then we also need to talk about equipment, so the diagnostic equipment, where again we see a positive development, but the current level in the country is still low compared to the EU average, and probably also too low to really meet the needs of all patients across the country. And the same goes also when we look a little bit more into the innovative space, so access to novel cancer medicines. Romania, unfortunately, it takes very long time for new medicines to be reimbursed. If we look at the proportion of medicines that are reimbursed, it's also low and quite far below the EU average, unfortunately. And I want to finish off on a positive note, because when we looked into the area of survivorship, we saw that when it comes to the right to be forgotten, which addresses access to financial services for cancer survivors, Romania is actually the first country in Eastern Europe that has adopted this right to be forgotten, which would help survivors to really to become to not face discrimination once they're cured from the cancer. So there's also really positive news in many areas, and I'm sure that Professor Schenker and his team will make sure that more of the red colors in this table will eventually turn into green colors. But it is important, and that's something that I want to stress again, to do this sort of monitoring on a regular, ideally yearly basis, to really track the progress and make sure you identify that the areas in greatest need of improvements. And going back, Stefan, to your initial question.
So, sorry, Dr. Hofmarscher,
Yes.
my suggestion is that we discuss this separately because...
happy to do so. Thank you.
Thank you so much for this overview. I think this dashboard you have built is a essential tool that must be transferred to other strategies in Romania. So maybe we discuss at the Ministry of Health level how we can create a template for monitoring implementation, if you agree, of course, to help us with that.
That would be fantastic. That would be fantastic. Thank you so much.
Thank you so much, and I'll follow up separately for my more technical curiosity on this matter. And with the risk of next moderator, Dr. Vlad Miksic, giving me hard time, we will be maximum 5 minutes over time. But before this, I want to give the chance to Lucian Besnea, Capital Equipment and Solutions Sales Manager for Romania, Moldova, for the company Medtronic, to share us their point of view. I must say that at least in the cardio-cerebrovascular strategy where I've been working, your company has shown great openness to collaborate from the start in developing things.
Thank you, Stefan. Thank you. Yes, we do collaborate intensely in cardiovascular and cerebrovascular disease. And we also want to collaborate extensively on cancer. Because we as a company, we consider that technology, the medical device, and innovative technology are critical in today's healthcare and in today's treatment of patients. And as Medtronic, we are trying to invest in developing new technologies for early detection, for treatment, effectively treatment, and also minimally invasive treatment, and also for palliation. As example, the pain management therapies. Being specific to National Plan for Cancer, I'm not here to speak about the past or what happened or not happened, but to speak about the future of Romanian patients with cancer or not, and to find a way on how to collaborate, all from this table or from this room, for this panelist. We have the patients' associations, we have the Ministry of Health, we have international health institutions, and we have the industry. And in the end of the day, all of us from here, we can become a patient. And I believe that we need to invest today in technology in order to save money tomorrow. We don't need to expect to save money tomorrow if we are spending today. But if we are looking to 3 years, 5 years period of time, for sure, the Western Europe model and also other global countries showed that investing in medical devices and in new technology can save the money in the future. For hospital length of stay, quality of the treatments, and also the quality of life, which will go to less patients with certain disease. And looking at the, I don't know, I was very happy seeing in the National Cancer Program some specific amount for minimal invasive surgery and robotic surgery. But also, we do know from our experience in the market that the adoption of minimal invasive surgery in Romania, it's below 20% from entire surgeries performed in Romania. And if we are looking at the adoption of minimally invasive therapies in cancer, the percentage is even below. And this is not due to, this is in the end due to lack of medical equipment, of technology in the country, and also due to lack of education. And here in education, we as a company, and I believe also the industry, can help a lot. And actually I have a question for Mr. Schenker, just to save time. If the Commission of the Ministry of Health, looking further for the implementation of the National Cancer Program, intend to take a follow-up or to consult the industry into this matter? Thank you.
Yeah, I'm sure that we will have ample time to address this in the break. I'm sure that Dr. Schenker is available to facilitate this type of collaboration. And again, once again, thank you for being always available when feedback is requested for planning purposes of any kind in these initiatives. Thank you so much.
Also, I want to thank Aspen a lot.
Yeah.
And maybe for the future, we can use as a dialogue platform Aspen as a dialogue between industry and also the state, the public stakeholders of different programs, non-mandatory cancer. Thank you.
Thank you so much. Now, before wrapping this up, I think it would be a real shame not to take at least one intervention from the room, if any. On this, any curiosities, any burning? No, apparently people are hungry. Oh, yes. Jean, yes, go ahead.
I don't want to take the floor for long, but just want to emphasize and to raise the issue which was already addressed by a lot of panelists, and especially all of them, and also Dr. Hofmascher, the issue of governance. So this was his first point on the governance. Because, okay, I think there is institutions in Romania which are now in charge of, after having elaborating a strategy, an implementation plan. Now it's a phase which is very important, but this phase important should be in the hands of people having enough staff, enough money, and enough long-term vision, which means real governance institutions within the ministry and partnership with all the stakeholders. So if there is a kind of more explanation on this, what will be the kind of governance which will be in place in order to move forward, and not to move forward within the next 2 or 5 years, but within the next 10 or 20 years.
Important point indeed. So I think on this matter, Dr. Bușoi is best equipped to answer.
Maybe, yes. Of course, long-term planning in Romania is difficult. But what was really extremely significant is that the National Cancer Plan, at least, of course, I'm sure that at some point also a national strategy for tackling cardiovascular diseases had support from all the political forces and all important institutions. Then, of course, some details still need to be addressed, and there are some differences of opinion between stakeholders, but I think this will be solved. The political will is very strong, and we are looking long-term on this. Then I saw on the website, on the slide, that governance was seen as a good part of the chart. The problem is then when you go to the implementation of the political will, and there most of the areas where we had the red are very much related to the budgetary constraint and the need to invest more. And this is something that is above the governance of the program itself. The Minister of Health, the Oncology Committee, the National Health Insurance House, the ANMDM, and all the stakeholders.
National Institute of Public Health.
Yes, but to have the necessary funds, it's a little bit beyond the will of these institutions. It's a little bit a decision that should be taken by the highest level of the government, and be also assured that there is a strong popular support for this. And this is maybe the next step that we have to contribute all in order to raise awareness, to make concrete proposals, and to push the dissidents outside the healthcare bubble to take this decision.
Thank you. I thought that was crystal clear, and this is definitely the mindset we should all be in and calibrate ourselves with. So if there are none other questions, I would like to thank our panelists today and you for bearing with us until the end. Thank you so much. And it's no break this time. It's time for the next panel. Dr. Vlad Miksic.
Hello. We're just going to delve directly into the next slide. George, please. Into the next panel, not slide. So part of the panel on innovation in healthcare e-health, biotech, AI, and digitalization of the healthcare system will be present online. So we have, I wanted to start it by saying that this panel is a panel made in heaven, because the participants of the panel were kind of the perfect mix, the perfect combination. Unfortunately, we miss one piece of this heaven. So, because heaven cannot be complete only if every one of the saints are there, this will not be, unfortunately, a panel made in heaven. Dr. Alexandru Grogobete, the State Secretary of the Ministry of Health, just announced the organizers that he will not be able to participate and be present. He would have represented the government, the public sector, part of the discussion, which, of course, in Romania, given the healthcare system, the way the healthcare system is organized, is very important to be involved and to be at the table. Nevertheless, I don't know if we already have online the other guest speakers. Yeah, we have. Okay, that's great. So, she's the representative of Maitri. She's the managing director for biomedical innovation. She's a health policy lawyer and bioethicist. And I will ask her briefly in the opening to describe a bit what Maitri is and the role this organization plays, because I think could be a very, very good model for Romania too, is the neutral actor, stakeholder, which is the producer of knowledge in the same time, but not only also managing, if my understanding is correct, quite an important stream of financing. So all like a really up to the manual think tank in the end. I also want to welcome online Dr. Adrian Bot. He is the researcher / businessman. He is the founding chief scientific officer and executive VIP of research and development of Capstan Therapeutics. But besides all these titles, he is a highly well-respected and experienced scientist in the discovery and development of immunotherapies and cell therapies, and a long friend of Aspen, Romania. Welcome, Dr. Bot. Also want to welcome on my left side Dr. Laurențiu Dașcă, who is basically representing the private player here, but not only, of course. Dr. Dașcă is a country manager at Arenzia Exploratory Medicine, Romania, and he has a rich experience in healthcare management, both in the private and public sector. And least but not last, George Haber. He's the entrepreneur by excellence, and he's an investor in early stage startups, mainly, but not only in the healthcare area. He successfully funded and exited a number of IT companies. So he represents the spirit of capitalism. If you see there, it's a very good title. We have prevention and innovation. This panel is dedicated more to the innovation part. If on prevention, we know how to do things, but we don't have money because there is not a lot of business interest there, so that's the problem. When we are talking about innovation, there is a lot of interest, lots of money, but nevertheless, we still don't know how to do everything when it's about introducing concretely innovation into healthcare system. And the purpose of this panel is trying to bridge among the hype and the glitz of these discussions around e-health, digitalization, AI, which started several years ago. And we are trying to bridge between this hype and glitz and the real life of healthcare professionals the real life of businessmen who are working here in Romania in the field, and of course, patients. Because many times, patients' lives is not very strongly influenced by all the hype around this industry. So I will stop my introduction and go directly with the opening question to you. So the structure of the panel, we will have an opening question for each of the participants, and then we're gonna go through discussions, and if you'll have questions, of course, please, you are more than welcome. So my first question for each of you is that even if of course, e-health, especially in hospitals, kind of under-delivered until now. Medical doctors, many times, they don't see the success or the usefulness, at least on bureaucratic stuff, coming from e-health. On the other hand, AI is really very to the fashion right now. Everyone speaks about AI right now, but in many, many countries, as Romania is the case, it's just a beautiful story. So, in the same time, you already know that there is lots of regulatory efforts to tackle and regulate this area. Just this morning, WHO published a really rich and important document on how to regulate AI in healthcare, and of course WHO is only one example. So it means that the future is already here, because when the institutions are already starting to regulate something, it means that things are going on and happening. So in a country like Romania, what is, and I want to start by addressing, invite Erin Williams to answer this first question. In a country like Romania, or similar profile with Romania, what is the first thing that should be done in order to move the needle a little bit? So let's try to make a step back, nothing very high level, and just try to advise for free all the people in the room, maybe also the stakeholders present here. Please, you have the floor.
Sure, thank you so much. Can you hear me all right?
Sure, we are hearing you and seeing you clearly.
Wonderful. Well, it's a great pleasure to be with you today virtually. Thank you, Vlad, for the nice introduction. As you mentioned, MITRE, the company where I work, we're a not-for-profit, and we work very closely with the federal government in a specialized role, operating federally funded research and development centers for them. So we're close enough so that we can access sensitive data and sit on their side of the table, but far enough away from government that we can still tell them, give it our objective opinion when something isn't going right. So anyway, it's a great pleasure to be here. To answer your question, look, I think a dogged focus on outcomes really is the way to go. There are many types of things that could happen in order to affect healthcare there. We've done a lot of work in the US on looking at how to mobilize the private sector. What can the government do? Not necessarily by spending more, but by taking the resources that it has and investing them in a certain way. How can it mobilize the private sector in order to be able to, attract the funding for things, in order to be able to attract the kinds of research that are going to be useful, and looking at that kind of thing with an eye toward economics and putting it to, because that drives so much of what happens in healthcare. Do you have enough staff? What kinds of screening technologies are being developed? And staying focused on outcomes where you can look as well at where the gaps are. I heard earlier in the panel, a focus on screening for cancer, for example, really understanding the root cause of why screening is not, is it that the screening is not available? Is it that people have a transportation issue and can't get there? Is it, are there ways to resolve that with mobile screening, or maybe with transportation and putting a little funding there that could help. And I think also learning from the experiences of others is really, really important. I mean, AI has such great promise, but there have been some epic fails, for example, with AI screening, identifying everything but COVID. So, for example, being trained on data where sicker patients that had COVID were lying down and healthier patients were standing up. So the AI learned that if you're if you're one way, you have COVID, and if you're a different way, you don't. Which isn't, the lesson that it's not what the AI should be telling folks. Or there was AI in the U.S. where it failed to flag Black patients for increased interventions for certain kinds of disease because of an anomaly that associated spending, increased spending with an increased need instead of learning, what was underneath. There are many examples and related to privacy as well. So I think investing as well, coming along with standards that are being developed, and participating in that can be very, very helpful. And that combination of things I think can help with the next steps. Over.
Thanks a lot for your intervention, and I'm just going to go directly to Dr. Adrian Bot. You are in the fortunate position of knowing very well also the biotechnology area, how things work in the States, but you also are familiar with the Romanian healthcare system. So I know this is a difficult question because I'm asking you in a couple of minutes to go from a very complex landscape to something very concrete. But the question also remains for you too. So Dr. Bot, what would be the first thing that you've done here in Romania in order to move the needle a bit? Very importantly, why to move the needle a bit, or towards what? Towards making a concrete impact into the life, positive impact into the life of patients or medical doctors, something very close to their skin.
First and foremost, Dr. Miksic, thank you very much for the invite. It's a pleasure being on this distinguished panel. Secondly, I'm coming from the biopharmaceutical industry ecosystem in the US, which is geared towards innovation cycle and shortening the innovation cycle. I think one of the important objectives in Romania, in my opinion, related to care and digitalization is to integrate Romania also in a larger ecosystem. And one aspect that would help a lot, in my opinion, the physicians and the patients would be actually to integrate, generate and integrate and optimize a system to collect data and share data across hospital with regulatory bodies as well as with the biopharmaceutical organizations or companies that are introducing new treatments, to monitor safety concerns, efficacy of new treatments, as well as publicize or socialize side effects and approaches to mitigate those or to manage those in clinic. Through that particular lever, so to speak, one could realize actually more benefit to the patient, as well as integrate Romania in a larger ecosystem. Thank you for the question.
Thank you, and thanks a lot for your very up-to-the-point answer. Dr. Dașcu.
Hello, and thank you for the invitation. First of all, I will mention something regarding the access of the patients, because many hospitals have to adapt themselves as the private organizations, private health organizations, are organized for the access. So electronic system of getting in the hospitals, making appointments, not only through emergency or relation with the registration of the hospital. There are already many hospitals who started to do this in the state sector. The second part, it's regarding the doctors and the medical activity. And there is already in place the CHIS, the hospital informatics system, but this has to be adapted to the needs in order to decrease the workflow, because lately in the last 6 years, 7 years, since the National Authority for Quality were implemented the norms for the quality in the health system, the working load was very much increased. So there are already hospitals who started this project. In our presence, it's Dr. Alida Moise, who implemented already a system like this. I say hello to her because we were looking as a pilot model for this type of project, and she decreased the workflow of the medical activity, not only for doctors but as well for the nurses. In
a state or a private?
In a state hospital, military state hospital.
Ah, okay.
Yeah. But it can be a pilot project very useful for all of us. And the third part, it's related, so first is the access of the patients, workload of the doctors and nurses, and third part, it's related with the system. So the system has to be integrated in all the parts. And actually, when I was manager of the state hospital, using my experience in a private sector, as a private hospital as well, I tried to implement that. And first of all, I put in place the position of innovation director in the hospital. And we worked on each of the parts of the hospital. We started with the surgical part, because this is the engine, the operation rooms and the surgical part, and then we started looking further with the IT in each department. This is the main thing, that the first 3 steps that we have to do, in my opinion.
Thank you for your answer, and I will just take an element of what you've just said and go to George.
Can you hear me?
Yes.
Can you see me? Can you feel me? Good.
Yes.
So I will say with very high level
there's
things.
The thing, but let's try to bring the balloon.
It's hard. It's hard to come down.
It's lots of discussion.
When life is beautiful and opportunities are actually great to innovate. So intelligence in general is the solution to most of life's problems. We agree? I think we do. Artificial intelligence is no different than human intelligence in its ability to solve problems and its mistakes that it makes from time to time. We agree with that? I think we agree with the next statement as well. Healthcare is an extremely complicated problem. It includes lots of moving parts. Demand from sick people or prevention, then buildings that have to be heated, cooled, doctors and nurses that have to be paid and taken care of, doctors that need to take risks in intervention. So it's extremely complicated, scary, but I tell you, government, at least in history, looking back, maybe now with AI, it's possible, has never solved complicated problems. It mostly came from private companies, entrepreneurs, the crazies of the world, as Steve Jobs used to say, whom I met and So as an entrepreneur, I see all the problems as opportunities to create solutions, to innovate, to make it better for everybody. And I'm willing to put a bet here. It's recorded, so this system can be 10 times cheaper, 100 times better for all the people involved, patients, doctors, governments, if it adopts the right AI solutions, and if what I promise is not true, shoot me. I'm willing to stand here in this hotel and be executed in a couple of years if this is not true, because I believe in it so much. So I'll let the rest of the world speak. It's doable.
So, Dr. Dashko was, thank you for your optimism. You, George, you're always, you were an optimist and thought in the good heart of the human nature, yeah, in the good side of the human nature. So thank you for this. Laurențiu was saying earlier about interoperability, and also Adrian Bot was emphasizing this issue with interoperability of data. Let's try to think more a bit about Romania, where things, to put it in an elegant way, are not yet there. So how AI, which is, at least in healthcare, a new technology, how AI, generally, many of us here, we are speaking about AI, but we don't really understand in detail how AI works, how machine learning works, and so on and so forth. And usually that's one of those ingredients which increase the chances for a huge failure. Because when you don't understand exactly how you should cook the soup, of course, the chances increase that you will not cook the right soup, or even worse, you will not cook a soup. You just label it as a soup, but it's not a soup. So, solutions. What kind of very practical examples of solutions AI can bring into connecting data from different, very heterogeneous healthcare providers? And these questions is for each of you. I see Laurențiu wants to answer first, please.
There are already in place some principles. The first, the main principle is to have big data in order to interpret and then to have conclusions regarding the process, the diagnostics, and the measures. So, for instance, the first example that I'm coming now, it's regarding the teleradiology and specific on the diagnostic programs in radiology. Because the oncological patients needs a lot of scans. There are a lot of data in their past, and when you give an exam, you have to fulfill a lot of requirements regarding the level of disease, how it was after the treatment, and it's a lot of work. And then that's why the most important companies in the high-tech imagistics developed programs, high data-based, and they are able to make diagnoses sometimes better than a doctor. I cannot say that, but and it's very easy for them. They are already used in teleradiology. So in that phase, many of these companies already have this in place. So they are used to help the doctors to get the results in a shorter period. It's about efficiency and the quality of diagnostics. Another part is teleradiology as well. And some other parts are focused on different fields, but I'm letting the other speakers to have
Sure.
their answers, and I'm coming back.
I direct my question also to Adrian Bot. So from your experience, have you seen a very clear example of I don't know, machine learning AI solutions used to increase this communication between hospitals, between healthcare providers or other players in the field when the data are very heterogeneous, when there are no standards and so on and so forth?
Absolutely, absolutely. There are very successful examples. By the way, we tend to call artificial intelligence machine learning, at least on the West Coast more recently. But in the course of developing new pharmaceutical agents or new medicines, we have what we call pre-feedback loops in preclinical stage, in clinical trials, as well as in real world with drugs that are approved or therapies that are in use. And these feedback loops allow us actually to generate large integrated data sets, heterogeneous data sets that are utilized in a centralized fashion through machine learning, for example, in order to detect signals related to efficacy or safety, toxicity aspects, access, reimbursement, and so on and so forth. So this type of information has been utilized successfully to accelerate the development approval of cell gene therapies, for example, in cancer, where I was directly involved in, and also lay out the foundation for next generation interventions. So this is an extremely important tool for us, at least in the US, in order to accelerate innovation in the biopharmaceutical field. Thank you for the question.
Thank you. And George, the same.
Yeah, so AI, to explain it at very, very high level, is no different than human intelligence. All intelligences, the cat, the human, the computers are learning from data that they read and catalog and categorize. And then the interesting part is the fantasies, the dreams. All of my life, I was wondering, why do we sleep and why do we dream? We sleep to regenerate, but half of the body's energy, 60%, which the brain consumes when we sleep, why is that? And then when AI started to be successful, it dawned on me that actually we do the generation of examples from what we learn to generalize them. And at sleep, we become smarter because we fantasize. We imagine things that are based on realities that we've seen or not, and then it's a cuckoo person. And we use that. So this is AI, and as such, it complements all the doctors. It helps them recognizing from my voice now that I speak. It can recognize if I have a heart problem or if my lungs are not healthy, which also a very good doctor would say, hey, George, go stop drinking or whatever. So this is the fantastic power of AI. And if we embrace it, as I said, 10 times cheaper, 100 times better for the doctors and the patient. If not, shoot me here. It's, I mean, I can feel it, and we all can see the results. Recognizing X-rays, pulse, you know, and a lot of other things.
So let me try to play the role of the public decision maker, and just asking you, whom should I talk to? This AI is marvelous, yeah? It can do marvelous things. I just want something simple. It's not simple, but simpler than, I don't know, having a great accuracy in diagnosis melanoma. I just want that a Romanian patient would be able to go from a hospital to another hospital, regardless if it's a private or public one, and the doctor should just write down the ID of that or using the e-health card, yeah? And immediately all the history of that patient would be on the screen, so that the patient will not have to, go and take all the files, run and make a special trip to a specific hospital in order to take the CT results. Some doctors in mid-sized cities are still asking for scans on CDs.
That's the 10x cheaper right there.
Yeah, so.
It's doable.
I know, but
you can do it today without AI. You should be able to do it today without AI by having the right policies from the government.
Okay, so it's about policies. Erin, if you hear us, do you have any nice case studies when this worked in practice, like some solutions which is based on automatization, because in the end AI it's about this?
Sure, yeah, several to draw from. I'll add just a little context for what I can share. I'm not an expert in the Romanian healthcare system. I did do a little bit of snooping around and looked at OECD numbers, comparing the US and Romania, because I am very familiar with the US system. I found that the US spends many times more of its GDP and about 10 times more per capita. I'll say our health outcomes are not 3 to 10 times better, though, in the United States. So I think there are lessons that can be learned on all sides. Regarding examples, there are some really good ones. We're looking at, systemic approaches that will enable a lot of things, like a standard health record, one patient, one record, one that's portable with the patient, for example. But even today in the US, some things are done not just by CD, but by fax machine, that records are transferred from one place to another. We have all these electronic records, but they're not interoperable. The reason they're not interoperable is part policy, but in part financial incentive. There's not a financial incentive for folks to pay. So the economic piece is really important to look at that. And there are some great examples of work being done in AI specifically about looking at how to make it more trustworthy, that it's important that it be useful, so it's valid and reliable and testable and beneficial, that it be safe, that it be transparent and accountable, that it be explainable and interpretable, and the like. And so there are a lot of efforts going on, and they involve necessarily government and also the private sector that's doing a lot of the development, because there really is a shared interest in making it work well and know that it's working well. So there are some great specific examples. We've done some work at MITRE on resolving ambiguity around something arthritis, where rheumatoid arthritis can be very complicated to diagnose and complicated to treat, and there are many factors. So we've used AI in order to have data-driven diagnostic approaches to improve patient outcomes, and there's been some success there as well. For children's healthcare, there are a few examples. At the University of Virginia, we partnered with them to look at to try to predict and prevent in the NICU when, like before it even would show up, when staff-related infection and others were likely to be present and cause health outcomes that were, cause death and other negative health outcomes. We were very successful in being able to look at early warning signals to detect them using AI technologies and be able to save patients' lives by providing the staff with some alerts and enabling earlier interventions. We're looking at it for mental health as well. One area I noted a distinction where Romania is doing much better than the United States is actually death per 100,000 due to mental disorders. Romania is at about 1.1, and the US is at 42. So we're 40 times worse. I could think of a lot of reasons that the data may show up that way. But there's a lot of interest in the United States and, being able to diminish the impact of mental health and treat it better, especially over great distances. So there's some very good examples, very specific examples about ways that AI has been used in order to be able to improve health and improve outcomes. There are also some very significant efforts underway across the U.S. and within MITRE related to cancer treatments, developing something called M-Code, which is related to identifying the specific data elements that already exist in electronic health records and the like that can be used for cancer diagnostics and tuning treatments, and also for research. If things are going well, there is a really beautiful synergy between patient care and the electronic health records, research, real world data, and the like. But it requires a lot of attention to the standardization, to knowing what data is being used in what way, and also to privacy and security.
Thank you. Erin, I will just take the opportunity to ask you, explain a bit more what's MITRE basically, because it's, in my opinion, it's a very interesting body. We don't have something like that in Romania. As a matter of fact, even if we have a thriving IT private sector, it's still, things are still lagged when we are talking about e-health in the public governmental arena. As a matter of fact, we are waiting to see the e-health, the digital strategy, which, as far as I know, was presented to some high public servants at the EU Commission. But what is MITRE? I mean, because you are also using public funds, federal funds, isn't it? Or managing federal funds?
Right, that's a great question. So MITRE is, essentially it's a not-for-profit organization that works with various parts of the federal government and the private sector, focused on creating a safer world and, solving really difficult problems that are system-wide across government. We have about 10,000 people that work in our organization, so it's large. It's not, I mean, there are bigger organizations that exist, and the people are deep technical experts in many different kinds of things, in cybersecurity and artificial intelligence, in economics, in systems engineering, in policy and the like. And we engage with the federal government, and we work with others as well. We work with state and local governments. We work with some international governments, in order to provide deep technical expertise, in order to look at sensitive data that maybe wouldn't be available to others, because it wouldn't be appropriate. We have very, very rigorous conflict of interest requirements to ensure that the information that we're providing is accurate and benefits everybody. So it's structured in a way so that all the incentives are for problem solving and outcomes focused research. We work very closely with many parts of government, which actually provides a benefit across, because for example, we started a lot of our folks work very closely in cybersecurity with defense, but then we transition that information into that capability into health. And we have done a lot of work related to cybersecurity and medical devices and networked environments, and hospital systems, and developed playbooks related to what local systems can do, especially ones that are vulnerable and less developed, that maybe don't have the same resources available elsewhere. What can they do to help prevent cyber attacks, and what can they do if something comes up? So that's been a really powerful, and we also then advise the regulators. We advise our Food and Drug Administration, which is the regulator of medical products in the U.S., about what they should consider when they're approving medical devices, for example. And that's just one small example. We work broadly across the government. We are funded largely by governments asking us to do things. Like we do have some other forms of funding, but primarily our funding comes from the federal government itself, and we play this very specialized role.
Thank you. Thank you. Just a short answer from you, yes or no. Are you worried by data privacy issues related to AI AI applications in healthcare?
Yes.
Okay, so let me go with, thank you. Let me go with exactly the same question to Dr. Adrian Bot. How is this tackled in the biopharmaceutical field? If you have some examples when this was successfully managed, because the problem is there to remain, definitely. But can it be managed, and if yes, how?
I think that one of the key challenges in biopharmaceutical industry is to make sure that there is a continuous flow of information in an anonymized way, so that we can make use of that information almost real time. So accessing the information, integrating large heterogeneous data sets, including gene sequencing information, and making sure that we respect all the rules and regulations and HIPAA and so on and so forth, in a way that will allow us to utilization of machine learning to boost our capability to find the needle in the haystack, so to speak, to find those particular signals that will inform us on how to better utilize a treatment that is already approved, or how to develop a next generation treatment modality. And one concrete example is in the area of first generation of cell gene therapies. We call them CAR-T. They're famous nowadays in the US because they're curative in certain cancers. These type of immunotherapies are coming with some severe toxicities in some patients. They're very powerful drugs. These are powerful treatments that can really eradicate up to the last cancerous cell in some patients. But this comes with the price of what we call cytokine storm syndrome, a flu-like syndrome that can be managed very well in clinic if you have access to the appropriate agents, right? So the information that will help us and healthcare providers and patients is related to when this type of adverse events may trigger, and which patients, who actually is more predisposed to experience such adverse events. I think that this type of information, if it's accessed appropriately, will help the patient as well as the healthcare provider to have all the appropriate measures in place to preempt and manage better certain treatment. Thank you for the question.
Thanks a lot for the answer. Laurențiu, your company, Arencia, is working in the clinical trials area, if I'm not wrong, phase 1, phase
1B2A.
1B2A. So this is early, probably first in-person clinical trials. Here in Romania, what's your experience with collecting data using IT system, because probably you are using them, and privacy, because there is lots of, it's quite an important lack of trust in the country, both in the pharma industry and in the government. So it seems a bit tricky, huh?
There are some rules in the industry that we have to follow. On the other hand, there are data in our sites that are only in our network. They are not in the hospital network, so they are not exposed. It's important to know that these are very regulated. So we are following the regulation, the international regulations.
But what about those data which are present in the networks of public hospitals, let's say, or how do you deal with those?
We have two different networks.
Okay, so we should go back to...
It's like in the army.
Yeah, so we should go back to my initial question about interoperability, because there are many parallel systems, both in hospitals and in the industry, and the interface between them. So this seems a very tricky issue that we're not gonna solve before lunch, unfortunately. But let me go to another interesting dilemma. And George, you are the best person to start the discussion about who should pay for, let's say, an intervention like a software as medical device solution. This could be implemented in Romania already, yeah, in some hospitals. Who and how should pay for that?
So that is governmental policy, part of the social contract that Mr. Joanna is talking about as well, extremely clearly. We have a social contract by paying taxes with a government that is above us. And as part of the social contract, we should decide how much of health prevention, which is the most important, 1 ounce of prevention is 1,000 kilograms of payment, then medical expenses, and then education of resources, doctors, training, AI, and so on and so forth. Regarding the data security, it's no different than humans. A human in a hospital can copy on a USB drive or send an email with all the data. AI has no incentive to do that. So it's in a way policy, but I think the innovation will come from inky-dinky little startups that will show the way, and then the government will decide if they adopt or stay behind. That it happened throughout human history. The same thing, the social contract between the Romans and Caesar after he burned Rome. I don't think the Romans were happy.
I mean, you're definitely right, but if we are thinking at some very current issues, so how would the medicine agency in Romania know if to recommend for reimbursement? I mean, of course, you don't know that, but I'm just out loud thinking, like a big brainstorming session. How they should do it? What should be the pathway in order, for instance, to be able to reimburse and approve something like a software as medical device solution? How can you establish the endpoints exactly to have relevant endpoints on this? Because you cannot wait. I mean, should you do this looking as we are looking today at other EU regulatory agencies and bodies, ignoring completely the huge issues of transferability of clinical endpoints and clinical data in the end? Or if we are talking about this kind of software as medical devices solutions, they are highly cultural specific, way much more than, I mean, they are way much, because they are behavioral interventions many times, yes. So should we wait for this to develop here, or should we just try to find, just go, no regulatories, just do a pilot innovation fund, something like that?
That's the way. You try
no
it.
rules, just try to...
You try it. The hospital will decide if it's good or not. Erin, I will be back in Virginia tomorrow, I think, so I'll contact you and we'll have a coffee or lunch somewhere in the area, and we can talk about what we can do for the US. But, by the way, many of the new things will be significantly cheaper than the IT solutions that you're buying from the giants that actually don't really help you solve this problem because they wrote that software 100 years ago.
Laurențiu? Yeah, thanks.
HTA issue, it's a very long story in Romania, but fortunately, in the next 6 months, this is a priority for the ANME, as I know. On the other hand, those companies who have something innovative as products, they usually have international studies regarding their innovative things, but sometimes, lately in many occasions, they gave the devices to some hospitals in Romania, or they gave medication to the hospital. Institute of Oncology has many projects like this. And on the other hand, when it's coming the focus on the new medication, it is asked the conclusion of the specific commission of the health ministry. So when you have a new medication,
I was afraid of this answer. So if innovative therapeutic solutions would go to the Ministry of Health, medication, yeah, maybe. I just want to stop because, as I told you, the main problem with this panel was the lack of time. Aspen can organize a specific forum only on this topic with way much more concrete, detailed discussions than these high-level discussions. I just want to ask you from the room if anyone has any question. Okay, so if not, I just want to thank all the guests. To just don't want to forget anyone. Thank you, Erin. I encourage you to search and Google it. Maitri is in Romanian is Mitre. It's a really very, very interesting organization and body in the state. Thank you, Dr. Bot. Thank you, George Haber, and thank you, Laurențiu Dașcă. And lunch is waiting for you. I was asked by the organizer to tell you that lunch is waiting for you in the restaurant. And thank you for the whole day, and looking forward to meet you again next year, probably. Have a nice lunch.
Thank you.